Welcome back to Dr. Ab's podcast. Today I have an incredibly experienced person in the field of cosmetic treatments and cosmetic surgery. His name is Karlo Hasenohrl, and he has been a plastic surgeon for 32 years. He's seen trends come and go. He's seen treatments come and go. He's seen instruments and devices come and go. And not only that, but he has even played a part in the development of techniques in plastic surgery as well. He's looked inside people's faces to see what actually happens when we age. He's treated so many people that he can say with confidence, what's the best way to prepare for surgery? What's the best way to heal? What are the best things to avoid if you want to make sure that you are aging well? So, Carlo, thank you very much for joining me today.
Thank you for the invitation. It's really exciting.
Yeah, I mean, you've literally flown from Austria to London.
Yes.
And come straight to this studio. So I'm very, very grateful for your time. I know you're a very busy person. So I want to start off by simply talking about how you got into plastic surgery. Could you tell us where you went to medical school and where you started? Because you're actually in the same clinic now that you started in, aren't you?
It's even worse. I've studied in the same city. I'm from Innsbruck in Austria. And I did my studying all in Innsbruck. And started also my career as in the clinic in Innsbruck. And the thing is, how I came to plastic surgery was not the direct way. My father, he was a general surgeon, and when he saw that I was going in his direction, studying medicine, he said, don't do general surgery because general surgery won't exist for very much longer. It goes apart in different directions. So do orthopedics or traumatology because there are always trauma, and so this is safe. And I was going to traumatology clinic and as a student, and was watching how they behave, how they treat their patients, and it was very, very, how to say it. One person saw the patient the first time, the next one was operating on him, the third one was taking care of afterwards.
Continuity.
There was no continuity, and so I said, no, that's not the way I want to treat my patient. I want to say hello, treat him, and say goodbye, but as one person.
Yeah.
And so I said, no, this traumatology is not mine. So I never had any contact with plastic surgery before, but I think plastic surgery would be something for me.
Yeah.
And so I started, and I told everybody I want to do plastic surgery. And then study and the training, and then I got the offer to start on plastic surgery, and I never can imagine that there's something else I would prefer to do.
Yeah,
it was the perfect choice.
Yeah,
I was really lucky.
Yeah,
say.
And 32 years later, you're still doing it.
Yes.
In the same place. And what I think is remarkable about that is we live in an age, in a world where in many different countries, people with not much experience are doing dangerous procedures.
Yeah.
And it's very common to see that a particular clinic has opened, done some questionable procedures, and then disappeared.
Yep.
To be in the same place for over 3 decades, I think actually says a lot about the quality of the relationships that you have had, the quality of the feedback that you have had. That when I first learned that, when our mutual friend Astrid told me, that's when I realized, okay, this guy is going to have some good stories to tell, which is why I wanted you on the podcast straight away. In fact, when I first met Carlo, probably within an hour, I thought, I want this guy on the podcast, and we discussed it pretty quickly. So I'm very grateful for you being here, and 32 years, and you're still going. You're still there. You've got now the 5 other plastic surgeons in the place. And what I want to ask about is, to start with, when you first started plastic surgery, obviously we didn't even have electronic records back then. We didn't have the communication that we can have with patients now with WhatsApp and all these sorts of things. So many things have changed in terms of the world around us. But in terms of the plastic surgery, what kind of things have you seen change? So, for example, let's start with this one. What about the perspective that the public have, or the views they have when they come to see you? Are they less scared of it now? Are they more accepting of it now? Are they more open about plastic surgery now?
The first thing I would say is they're more demanding.
Okay.
They know so much from social media, from media. It's in every kind of way, and they are many of my patients. They have very distinct ideas what they want to have, and it's not always the right thing for them.
Sure.
And this is I'm very happy that I'm in a position now where I can say, I tell you, this is not the right way for you.
Yeah.
And I think it's so difficult when you're rising, when you start your business, to be in danger to lose your patient because you want to satisfy him,
of course,
but you know that it's not the right way. And the moment you tell him no, do it another way, he will say, okay, then I go somewhere else.
Yeah.
So this I don't care. Yeah, and this gives me so much, makes me really happy and gives me confidence that I can do the best for my patients, even if they don't agree at the beginning. But when it's fine at the end, it's for both of us, it's a success. And this is something that really has changed a lot.
Yeah.
Because at the beginning, people were sitting in front of me and said, "Doctor, what do you want to do with me?"
Okay.
And I hated this word. I hated this question because I thought, well, when I tell her that her nose is too long, she will say, "Oh, I love my nose." So it was also not so funny. But at the end, it was better because you could guide your patient. You could tell him what to do, and what's the best for him, and not always the most expensive, the most effort is the best way. It can be very simple.
Yeah.
And this is something that at the end is so important. It gives you the quality and gives you the long-lasting results and the good reputation on the same place.
And I think you said something really important, which I think most medical professionals in the world would agree with you on, which is a patient will ask for something that's not necessarily the best for them. And you also said patients know more about or know more types of procedures now because of the internet, social media, etc. And I guess that's why they're coming and asking for things, because they've seen other things. Can you give me an idea of what kind of common things patients come to you asking for that you think is not the best for them? Can you give me some examples of common things that you see?
Yeah, it's especially with new devices that are on the market.
Sure. Home devices, you mean?
So more or less, or also devices they've heard about, and they say, well, I've heard about a laser treatment, for example.
Okay, yeah.
And I see that this woman is always, especially in my area, in the mountains, skiing, walking, and she wants a full face laser treatment. I said, no.
Yeah.
I say, no, it's not the right thing for you because it gives your skin too much stress. It will destroy too much of the protection for against the sun, the intense sun in the mountains. So I say, let's do something else, do some regenerative, and they this is, for example, this is an example what you said. Yeah, that they
don't understand the risks necessarily.
Yeah, right.
Of what they're asking.
They've heard about this treatment. They have heard that her friend looks perfect after this treatment.
Yeah.
But she's not as sporty or as much exposed to the sun as the patient in front of me. So I say we have to find another way.
Yeah.
And this is important to not to go too far with the patient, just to fulfill the ideas, the needs the patient thinks is the best for them.
So when you let's pretend a patient is going to come to see you in 3 days' time. You've got an appointment with a particular patient and I know they're going to ask for this laser treatment, and you're going to say it's too much. What kind of advice would you have for those patients before they came to see you?
They should just ask to be treated for something they are concerned of.
Okay, so they should ask for a goal and not a treatment.
Right.
Yeah.
Give the doctor free hand so he can really look what's the best thing for this patient.
I completely agree.
Yeah.
And I think what patients want is not the laser treatment. They want to look good afterwards.
They want a good result.
Yeah. And I think it's very common for people to confuse the looking good with the laser or the surgery or anything.
Yeah.
And I completely agree. I always tell my patients, well, I can do that treatment, but it won't give you what you want. What you want is this. And actually the better plan is XYZ, not ABC.
Right.
And I think most doctors would agree with you. I find every doctor would agree with you when you say that. We all get it.
It's in theory, it's very easy. But when a woman is sitting in front of you and you see that she's absolutely concentrated on this and has her opinion already fixed, and then it's very difficult to change.
Same for me. For me. You just touched on when a woman sits in front of you. What about men? Do you find that more men are coming to you for these kind of treatments?
I hear this. This question comes rather often when we talk with friends or also with interviews, and so I would say yes and no. I have a very constant percentage of men. It's not growing in the percentage.
Okay.
There are more men coming now than 20 years ago.
Okay.
But there are altogether more patients coming now 20 years ago. So it's always, I would say, between 25 to maximum 30%, 25%, yes.
That's still more than I thought, actually.
Yeah.
I thought it was going to be maybe 10 to 15.
No.
That is quite a lot.
I was watching it for some time and I thought, well, it's not that small. It's not that small, such a small amount. It's not only aesthetic. It's different kind of treatments, but the aesthetic part is also not so small.
Yeah, sure.
The thing is, they don't want anybody to know.
Yeah, of course.
Much more interested in nobody finds out that they have done something.
Very discreet treatment.
Very discreet.
Invisible treatment.
Yes.
Yeah. And to that end, in terms of being more invisible, would you say it's much easier now than when you started to make treatments look invisible?
Yes. I always say at the beginning, people were not, I'm in a small city and people know each other quite well.
Sure.
So people knew me after some time because they knew that I was a new doctor. He's the son of a very famous doctor. My father was general surgeon, as I said, but he was quite famous in our city. And he's now doing aesthetic surgery. So they even pass by without greeting me because they are afraid that everybody says, oh, look, she's greeting him. She knows him already and she was there and well, let's see what she's done. Yeah. So, but this changed a lot. It's people are much more relaxed with this theme and they are much more open-minded in this case.
And do you think it's easier now to complete treatments without scarring than it was when you started?
This is a point I wanted to talk about a lot.
Please do.
Because we are all afraid of scars.
Sure.
Yeah.
Sure.
I agree absolutely, and it's our goal in surgery to make the smallest scars possible.
Sure.
Sometimes I discuss with doctors because they don't agree with my kind of technique, and I said, but in my technique I have smaller scars. Scars aren't so possible, so important, but they are important to everybody.
Yeah.
But at the end, almost everything we do in aesthetic treatments, in aesthetic surgery, is based on a scar.
Yeah.
We work with scars.
Yeah.
To lift a patient is the most obvious scarring you do.
Yeah.
You prepare the skin, you prepare the deeper layers, you lift it up. It's fixed by scars. It stays where it is due to the scar that it exists, even if you don't see it.
Yeah.
And you, especially you, talk a lot about inflammaging.
Of course, yeah.
And this inflammaging is generating a scar in the deeper layer to fill up or fix or to make something looking better, even if it's at the end it's not the best way, but it is still a scar. So we're working with scars. Yeah. And of course scars should be invisible, but they are our major tool. Yeah. We must be honest about this. Yeah. And everything we do ends at the end. There are only a few things like regenerative treatments, or, for example, if there is apoptosis, for cryolipolysis, for example, there are no scars. Yes. I'm happy that I have these tools, but at the end, liposuction is generating a scar, is producing a scar, a very big scar under the surface. So this is our tool.
Yeah, and I'm glad you said that, because I think scarring, when you say the word scar, you think of, a mark or something. That obviously no one wants. But there is a big difference between that and what a plastic surgeon is doing to hold your tissues in the right place. And I think patients don't always understand this. And I think it's another situation where you have to allow your surgeon to just work, in peace and do the right thing. And scarring internally, which is not visible externally, for the purpose of something surgical, if you don't want that, you can't have the surgery. Am I right in thinking that?
Absolutely right.
Yeah, I thought so. Yeah. And what about in terms of the overall risk? So, for example, if someone is going under general anesthetic, there are more risks than a local anesthetic, depending on the patient. Do you find that from when you started your career to now, today, we're filming in 2024, do you think the risk profile of procedures has reduced because of better techniques and better technology?
I agree, yes. I think it is like this, although I must say I don't agree when often patients coming and say, I don't want to have a general anesthesia, it's too risky. Sure. But it's not always like that. Okay. Because, for example, if you work in the face, if you do an operation on the face, and you have a patient in local anesthesia, and you do some sedation, so they are relaxed.
Like an IV sedation?
Yes, right. Yeah. And then the patient is swallowing something or inhaling the slavia or something like choking. Then everything is no more sterile anymore. Yeah. And you're in troubles then, because you don't have the access to the breathing, to the airway. So in this case, I prefer general anesthesia, because everything is blocked, everything is safe, everything. Sure. You have the tube that keeps everything away from the bronchus, and you can work under sterile conditions. So even the general anesthesia has changed a lot, in my opinion. Our medication has changed a lot. We don't use any gas anymore. We just do IV anesthesia, and so we can offer a lot of safety even in general anesthesia. It has changed. It has become much better, but it's not that that you can say local anesthesia is good and general anesthesia is
fine. It's not that simple.
It's critical. No, not at all.
Okay, so I suppose local anesthesia, you could only consider that best for an extremely small procedure, like maybe you're cutting out some kind of lesion. And obviously there's no need for general anesthetic with something like that. But for anything more complex, it's based on the individual. It's based on the procedure.
Absolutely.
Sure.
I've talked with anesthetists, and they said it's very simple. If there is a cardiac problem, it's better to do general anesthesia. If there is a pulmonary problem, it's better to do local.
Sure.
It's easy like that. And I must say, one thing that is also has changed is the age of my patients.
Okay.
They're much younger now than they've been before. Yeah. And so they are in a safer age.
Yeah.
It's the they get any troubles by the operation is rare because they are fit, they're healthy,
less medications.
They have no medication.
What would you say is the sort of, back when you started, what would you say generally was the youngest age that you would treat, and what does that look like now?
Well, it's a little difficult to answer because in my career, the treatments I've done have changed. The focus, the main focus. So
I'll give you 2 treatments specifically.
Okay.
One is a facelift.
Yeah.
And 2 is breast implants. When you first started, what would you say was the lowest age you would have for each of those? And what is it now?
Facelift, above 50.
Above 50, okay.
55 to 60.
Yeah.
Breast augmentation between 35 and 45.
Okay.
And this has changed a lot.
Sure.
Especially these 2.
Yeah.
Much younger patients coming for breast augmentation.
Yeah.
And much younger patients coming for facelifts.
Okay.
I'm happy about this.
Okay.
Because you can do much more if it's not that...
It's not as aged.
Yeah, aged.
Yeah. So what would you say those ages look like now for those 2 treatments in terms of the
mid of 20s for the breast augmentation,
sure,
and mid of 40s
for the facelift. Okay. So it's a little bit younger, but not a huge amount.
Yeah.
Yeah.
I got older. Perhaps my patients got aged with me.
Yeah. Interesting. So, would you you mentioned the treatments aren't necessarily the same. Would you say that you are able to do many more types of procedures now, or in general, as a plastic surgeon, than you were back then?
Yes, and always I have to say yes and no.
That's okay. That's
Sorry
okay.
about that.
That's okay. That's totally true.
There are a lot of treatments. For the same thing, for the same problem.
Yeah.
You have a lot of machines, techniques to treat patients.
Yeah.
Endoscopy. I'm working with endoscopy in the face since 1969.
Wow.
And I've seen, first it was hype. Everybody wanted to be treated endoscopically. In the meantime, nobody's talking about it anymore.
Yeah.
So it's also it changed. The technique changed, but it didn't go. Not everywhere went further. It also went back.
Ah, okay.
Yeah, it's the old techniques came back and were quite okay.
Yeah.
And the longer you're in this business, the more you see. I've seen that before, 10, 15 years ago.
Yeah.
And then suddenly it disappeared because there were some problems, and now they solve these problems and they bring it up again. So this is very exciting when you're this long in this business. You see so many changes and things coming back. Yeah.
And that's why I wanted to speak to you. So in terms of these techniques, is that quite common to see things disappear and then come back, disappear and come back?
Absolutely.
Yeah.
Absolutely. And they have a new name.
Yeah.
And a new star who just brought us this new technique, and I sit there and listen at a meeting or a conference and think, okay, I've done this 25 years ago. It wasn't my favorite one, but it worked somehow in special cases.
Yeah.
And now he thinks he can do it everywhere. So let's see what's coming out. Yeah. And also I look at the differences, the
what they've updated.
Small updates they've done or changed techniques, and somehow it works really. For example, especially in endoscopy, there is one famous colleague now, he's in California. He's brought out endoscopic facelift once again. He gave it his own name, and I was was listening to him in a webinar, and I was sitting there, and I said, okay, check this. I've done before with this technique, and I've done this with this technique, but here I did something else, and I think if I do this like he's doing it, perhaps it's just the right way.
Yeah.
That the technique's improving.
Okay.
And this is really exciting. This makes it so always new, always something you learn with CC, and that's great.
So just because something is new or old, it doesn't mean it's better or worse.
No, absolutely
you have to
not.
study it and analyze it and see what it's doing.
Yeah.
Perfect. So this is something I'm very curious of. When you take a scalpel onto someone's face and you peel the skin and you look inside the face, I want you to imagine there's two patients here. You've taken a scalpel and you've looked inside. Now, you don't know which patient is young and which is old, but you can see inside their face. What do you see that allows you to judge which patient is older or younger? What does the inside of the face look like when it's younger or older?
It's how the tissue, the feeling of the tissue. Okay. There is more stretch.
Okay.
It's younger tissue is more tight.
Okay.
Older tissue is more
stretchy.
Yeah, it's easier malleable to manipulate.
Okay.
It's more the different layers. They're easier to divide.
Okay.
Yeah.
More separated.
Yes. And younger tissue is much firmer, and the connection between the tissue layers are more firm.
Okay.
In general.
Okay.
Also here, it's not that you can say, I'm sure this woman is 60 and this woman is 30.
Yeah.
But usually, yes, it's like this.
Okay.
It's much tighter, and you have another. The scissors go through in another way.
Okay, really, as you're going through the layers.
Through the layers.
Okay,
yes.
Interesting. And what about the muscles? Obviously, if you're standing behind a patient and you're looking down as you've opened the flap, you can see things like the zygomaticus muscles and the buccinator muscles, the risorius, the masseter. Do they feel different? Do they look different?
Honestly, I don't see so many muscles in the face because there is the parotid gland in between.
Fine.
And I don't. It's also a matter or a question how far you prepare. I don't want to go too far to the midline.
Fine.
Over the border of the parotid gland, because then it's getting dangerous. And why should I endanger or make it more difficult or more dangerous when I don't have the effect?
Yeah.
So I see the masseteric muscle. I see this, and I see the branches of the facial nerve.
Okay.
But the masseteric muscle, it's not really aging, in my opinion. It looks very similar to a young and an older patient, in my opinion. The thing is how they work with it.
I see.
Grinding or...
And if they have less teeth, obviously they're going to be making less force or be thinner.
Yeah.
And what about the orbicularis oculi muscle? That is something, obviously it's used very much. And, we do eye surgeries, blepharoplasties and things. Do you think there's a big difference in young and old orbicularis oculi muscles?
I really, actually, I divide it and I see the muscle directly.
Yeah.
Because I just take a little bit out of it afterwards. Not really. I don't see so much difference between older and younger.
And what about the amount of fat that you see?
Yes.
Now,
that's diminishing.
Yeah.
Absolutely.
Okay.
And it's changing its position, and it's changing the quality.
Yeah. What do you mean by the quality of it?
It's getting more vulnerable. It's breaking.
Okay. So when you hold it, it comes apart more easily.
Yes. Yeah.
Oh, interesting. Mm-hmm. Interesting. And what about the color? Does that look slightly different?
This is absolutely personal. It's not the age. It's the individual.
Fine.
I see very bright fat. I see very yellowish fat. but it's not depending on the
Fine.
age.
And when you see the position of the fat, because obviously the position will change as we get older, and it could come down. What age do you find? I know it's a broad question, and there's always a range. You can give me a range. At what age do you find that the fat, say here, starts to come down to here? In your experience,
Very young, in my opinion.
really?
Yeah, I think it starts in the 30s.
Okay.
Even younger patients I see with sagging fat,
Yeah.
especially here, especially in the eye area.
Yeah.
It's a little depending how it's a genetic too.
Yeah.
I've for example, my wife, she still has not so much sagging fat.
Wow. Lucky. Very lucky.
But although I must say I helped a little bit, but it's already, again, 20 years ago, so it's still on the same place. But so it's genetic. It's also makes a big difference. But I would say it starts rather early. That's
Okay,
really,
30. That is much earlier than I thought.
Mhm.
And in terms of when someone comes to you with a jowl
Yeah.
here, because that's a very common complaint all over the world, can you talk to us what you see inside a jowl?
It's mainly the fatty tissue sagging down. It's coming from the buccal fat,
Sure.
sagging down, and then it depends on where is the anchorage of this ligaments, of these retaining ligaments, keeping the fat in place, or even how is the skin
Skin quality.
Yeah. If the skin quality is not so good, then the retaining ligaments have no chance. Then they stay where they are, but the rest is sagging down.
Yeah.
So here is a lot of movement, and most of the time the best thing would be to bring it back where it has been.
Yeah.
Reconstruct it.
Exactly.
Yeah.
Now, in terms of the sag, from what I see in my patients in my clinic, I'd say the most common areas that I see for sag are from here to here.
Yeah.
And from here to here.
Absolutely.
I'm guessing you agree.
Absolutely.
Yeah. Fine.
Yeah.
Interesting.
And the eyebrow. It's not fat.
Well. Yeah.
It's the muscle, the tone of the muscle.
Yes.
I always, when we're coming back to blepharoplasty, in more than 9 of 10, I do a brow lift to the blepharoplasty, because most of the time the eyebrow is the most important part of the change in the upper lid. Yeah. Much more than the skin, excessive skin. Excessive skin is mainly the change of the distance between the eyelashes and the eyebrow. Yeah. When this distance gets less, then there's no space for the skin. Yeah. So then it looks like there is too much skin, but mostly it's just the distance that makes the problem. And if you lift the eyebrow, it's open.
Straight away. Straight away. So is there any particular part of the face that when we age becomes more difficult to treat, or is it just the whole face?
It's getting more difficult when there is very little amount of fat. When people are very, very skinny, even when the skin quality gets very bad, especially people exposed to sun for all their life, they are very difficult to treat. Fine. And here I think regeneration is much more important than reconstruction.
Fine. So if someone is coming to you for surgery, let's say you planned the surgery, whatever surgery it is, what kind of advice do you give to patients pre-surgery, maybe in the weeks leading up to it, to make sure that your job is as easy as possible, if anything?
And the advice to the patient, just look where is the problem, where is, if there is enough fatty tissue, if it's just changed position, then it's more a surgical treatment I should do. If there is a loss of volume, it's more conservative treatment that I would suggest. So
dermal filler or something.
Yeah, right.
Yeah. So leading up to surgery, let's say you have a surgery on Friday. Today is Monday. What do you tell your patients to do or not to do leading up to Friday?
And not to use any painkillers with aspirin, not to take care of their what they eat and what they drink, especially what they drink, especially with alcohol. Then no diet, no supplementary nutrition,
supplements and things.
no supplements, and just have a balanced nutrition. I think this here. What you eat is very important to give the body the resources to recover after the stress.
Right. And what would you say are the most common mistakes people make that is leading up to the surgery on Friday? What are the most common mistakes they make that makes it more difficult for you on Friday?
I think what we are really very, very concentrated to tell our patients, especially those vitamin supplements.
Right.
It's good it can be good afterwards, and we even suggest to use vitamins, to use selenium. And selenium, and I just know the German word, Folsäure,
Folsäure. Nein, ich weiß nicht.
Yeah.
Ich lerne noch. Carlo speaks my favorite language, by the way, which is German.
or arnica. So these, I suggest to use this afterwards, but don't ever use it before, especially, for example, arnica is homeopathic, and it provokes bleeding. Yeah. So they bleed much more.
Right.
And this is something that really gives us a lot of problems.
And what about the food in the day before? Do you ask patients to fast? Is it better to not fast?
No, I don't suggest them to fast, to eat normal, not too much, especially in the evening.
Yeah.
But eat what they need for calories. Don't exaggerate, but never fasting.
Okay.
I don't do this.
Yeah. And plenty of water as they need.
Yes, drink water.
Now, when you have a consultation with the patient, you are in a position where you're happy to say yes, you're happy to say no. What kind of things do you see and look for in a patient that suggests mentally there is a problem that makes you say no?
I try to convince the patient to change the opinion. It sounds very easy, but I don't think, first of all, something I'm rather confronted rather often with is that people are asking me, how many of your patients, how high is the percentage you say, I don't treat you?
Okay.
Yeah. And I say, I keep it as low as possible. We are all living from our jobs. Yeah. And also I am living from my job. So I don't want to lose a patient.
Of course.
But I don't, if I have a patient who has an idea of the treatment that I'm absolutely sure I cannot fulfill, then it's better to say no, because afterwards you have an unhappy patient who is always in your office complaining, and nobody wins. Yeah. So these patients you must separate and say, okay, sorry, but I'm not the right one for you.
Once you listen and once you don't.
Yeah.
Yeah, I completely agree. The same thing. So let's pretend it's Friday. You've finished the surgery. What is your typical aftercare post-operative instructions to your patient?
Well, I have a lot of different post-operative treatments. Starting with the face, for example, I don't use any compression.
Okay.
Never, because when I have a bleeding, I will have the bleeding with the compression. As well, I don't use any drainage.
Okay.
it has to be as it. They get we have special mask for cooling, yes, and they stay overnight because I want to take care if there is any bleeding or anything happening or she has pain. Then it's important that I'm nearby.
Okay.
So I do a lot. I want to have this 24 hours observation. This is very important for me. And then they should stay calm. They didn't no sports, of course, no stress, no homework. Be really. I say the more you take care of yourself in the first days, the faster you're recovered.
Okay.
This is the
in the inflammation stage.
You're right, and this is something that the patient can follow.
Yeah.
They understand. If I'm really taking care of myself in the first days, then I'm fine after a week or 10 days.
Fine.
If I say, I'm fine, I go for a walk or work in the kitchen or so, and then it can take 2 or 3 weeks to recover. Okay.
Just because of what they did at the very beginning.
Yes, right.
Okay.
This is very important in my opinion.
Is there any techniques or devices or routines that you use to accelerate healing?
Lymphatic drainage, manual lymphatic drainage. There's one employee in my office, she's just doing nothing else than post-operative lymphatic drainage. I think this is one major column of our success, I would say. Fine. And I work a lot with tapes, with kinesio tapes.
Okay, they're sort of the brightly colored.
Right, yes. For example, after breast augmentation, I never use a bra.
Okay, just the tapes.
Just the tapes. Because I'm convinced that you have to take care of the lymphatic flow. Yeah. And the bra closes the lymphatic.
Okay, so it's compressing the lymphatic vessel, so there's no flow.
Right. And this is why I don't use any compressions in the face, because also here it's compressing here the lymphatic flow to the neck, and there is a swelling, and swelling is less blood perfusion, less oxygen in the wound area. Of course, it is not good for the healing.
I completely understand the logic of that, because when we swell, it is for a reason. When a body undergoes trauma, be it a punch, surgery, maybe you fall, every single time the body will do what it needs to do to heal. And if it needs to swell to heal properly, I think it's doing that for a reason. Yeah. And so it makes sense to me that you're allowing the body to do what it needs to do.
Yes, absolutely.
And I guess that's something you've perfected now over all your experience. Mm-hmm. Was there ever a time where you did try compression?
Oh, of course.
So you've tried both, and you can clearly see there's a big difference.
Everybody suggested to take these compression bandages for the face. Everybody said you must wear a post-operative bra after breast augmentation or mastopexy. Yeah. And I did this over years. But since I've stopped using bras at the beginning, women have much less pain, post-operative pain. Wow. And they recover much faster.
What kind of recovery time? So from after the surgery to being able to walk to the car in without pain, what kind of time are we looking at?
24 hours.
Wow.
Yeah.
That's very quick.
They should be painless from the moment they're awake. Yeah. It doesn't work every time, of course, and not with every operation. There are painful treatments, of course. Yeah. But, for example, breast augmentation is called to be, especially when you put the implant underneath the muscle. Yeah. Everybody say, "Oh, this is painful. This really hurts a lot." Yeah. But if the moment you stop using a bra and you stop using a drainage, pain is much less.
Right.
Yeah.
Okay. Well, that leads us nicely onto surgeries. This is. I've been really looking forward to this because you've done so many things. Obviously, we're talking about healing post-op, and we've just mentioned breast, so we'll talk about breast implant surgery. And one of the things I want you guys to understand here is there are conventional methods of breast implant surgery, which Carlo obviously does, but there is a new technique which is very, very new. And Carlo was a very important person in helping that come to market, and he's one of the people that gave his opinion and basically allowed this technique to develop. So we're going to talk about the conventional breast augmentation surgery, and so also this new technique which Carlo has been at the one of the pioneers of. So in conventional breast surgery, could you tell us what it actually is? Because everyone assumes they know, but I think it's much more complex than just taking this and putting it inside.
Actually, it's more or less.
It is.
It is like. It is. Of course, there are a lot of nuances where
yes, that's what I mean.
Which you can divide, but in general, it's putting a cushion of silicone under the breast or under the muscle.
Okay.
Of course, you can treat patients. There are colleagues who only use fat grafting for breast augmentation. I always say this is something that is so uncertain how much of the amount of fat that stay that the effort, the operation is so much longer. It has a second area that has to be
taking the fat from.
And most of the patients who need a breast augmentation are rather skinny, so you need a lot of areas you must treat, and then you must repeat it after some time. So in my opinion, this is not the right way. It's breast implants. If you treat them, if you do a proper breast augmentation with an implant, it's really safe. It's as safe as any operation.
Sure.
You have your risks, no doubt about this. But it's reliable. It's we have experience over 50 years. Yes, I think 50 years now, and we had a lot of problems we had to solve, but at the end the implant stayed. And it's still if you want a breast improvement of your breast shape, then implant is the best way. And there are as you say, there are more or less two areas where you can put the implant too. You can put it underneath the breast tissue, and you can put it underneath the muscle.
Okay.
And this is something that's really interesting, because in my 30 years of treatment, there was like a trend. At the beginning, when I started, we mostly put the implants under the fat under the tissue, the breast, the gland.
Mammary gland.
Mammary gland. Then they started to go under the muscle, and for years, my patients came and said, "I know there are two areas where I couldn't put my implant, but I know the only way to put it on is under the muscle."
Okay.
And I said, that's not true. That it depends on so many things. And I always said the best place for the implant is the place that comes the closest to your imagination, what you want from your breast look like.
So you can get the same implant in different layers, and it will look different from the outside.
Yes, absolutely.
And what kind of differences do you see on the outside, whether you go under the mammary gland or under the muscle?
If you have a very skinny patient with very little breast tissue, and you put the implant underneath the breast, the gland, then you will see the implant.
Okay.
There are patients, they say, I want to have.
Oh, they want to see it.
Okay. I want to have this décolleté where you can really, where everybody's looking at. And then I say, okay, let's do it, no problem. But most of my patients, they want to have a natural shape.
Okay.
Drop, like a drop, or like a pear, more a pear than an apple. And then you must decide: is there enough subcutaneous tissue so you can put it underneath the gland, or do you need the muscle as a second coverage to make a natural shape?
Okay.
That's very easy. It's very easy. And when you explain this to the patients, they don't say, okay, I want to have it under the muscle and nowhere else.
Yeah, fine. And what about the entry sites? Do you go direct? Do you prefer to go under the armpit? What are the differences?
Okay. This is depending a lot on the region where you are working.
Okay. So which country?
In Europe, yes. Yeah. In Europe, in Northern America, even I think in Southern America, almost everybody does a submammary incision
underneath
in the submammary fold.
Yeah.
I started in the early 90s in my office, and I started with transaxillary augmentation. 2 reasons. I have a smaller scar.
Yeah.
Back to the scars from the beginning. And I have the area I'm treating is without any scar. You have no scar on the breast. You want to have a perfect looking breast, and the breast doesn't look perfect if there is a scar, in my opinion. Sometimes it must be like this, but it's always the decision between the smallest scar and the best result.
Sure.
And if you have the possibility to have a scarless breast and a small scar in the armpit, in my opinion, that's a good choice.
Yeah.
And so I started with doing transaxillary, and I was, especially in my area, everybody said, you cannot do this. You must change to submammary. It's so dangerous. You don't know what's happening with the glands, with the sweat glands. You don't know what's happening with the nerves, with the sensory nerves, with the lymph nodes. So there are so many things that can happen in the armpit, and I'm much safer when I go from under from submammary.
Yeah.
I say, if you're experienced enough and you have the will to have a good result without any scar in the breast area, it's the perfect place to put a scar. You don't almost see it at all.
Yeah.
You have a small incision. You can be much smaller.
How big is the incision?
2.5 to 3.
Wow, that's it.
Yeah.
That's very small.
Yeah, because I have long, thin instruments.
Okay.
I look at the tissue with the video.
Oh, so there's a camera on the end of the...
I do it endoscopically.
Okay.
Yeah, I do it with a video camera.
Yeah.
So the only criteria is the size of the implant. If I have a 400 cc's implant, it will be rather 3.5 centimeters. If I have a 220 cc's implant, it can be 2.5 to 3.
Okay.
So this is the only criteria, not my instruments, not how the cavity must look like.
Yeah.
Because this is very easily done with endoscope.
And when you make the incision, is it in this direction vertical?
No,
or is
it's
it
horizontal.
Horizontal
it's
like this.
It's in the second fold of your armpit.
Okay, so right there.
Yeah, absolutely.
Interesting. Okay. And how do you speak to a patient who is deciding what size implant to go for? Is there such a thing as an unsafe size as well?
Yes, I have in mind. I see the patient. I have an idea where is a critical size.
Yeah. And what do you mean by that? What do you mean by critical size?
Too large.
Okay.
Or too small.
Okay.
If it's too small, you don't see very much.
Yeah.
It looks unnatural because there's more or less nothing to changing.
Yeah.
And too large because then I cannot. The tissue will not cover the implant properly.
Fine. So you can see the implant.
Unnatural.
Yeah.
And for me there is a criteria. It's not, you cannot put it to all patients, but 70 to 80% of my patients, I look how much volume the tissue of the patient or the breast tissue has.
Yeah.
And if I put more or less the same volume of implant inside, I'm safe.
Yeah.
Yeah. If I have a breast that starts with about 220 cc's and I put a 250 cc implant in, I'm fine.
Right.
there will be no problem. Everything will work very nicely.
Yeah.
If I have 200 or 180 cc's and she wants 600 cc implant, trouble is more or less
right.
Clear. There will be trouble.
And what kind of trouble do you see there?
Complications like malpositioning, problems with the scar, then rippling,
visibility, I guess, as well.
Yes.
So if someone is, let's say someone has naturally very small breasts, let's say they are an A cup or maybe less in terms of their bra, but they would like to go for something quite significant. They want to go to maybe a double E bra. Let's pick a random size. What would you do in that patient? Would you maybe do a smaller implant and then over time swap them for bigger ones, or you just...
What I do with all my patients, I do a 3D scan.
Ah, okay.
And I have a program that shows the patient on the 3D picture how the body looks with different sizes of implants.
Okay.
And this is my major tool. Okay. So we sit together in front of her own torso. Yeah. And I say, well, let's start with 220. Yeah. And then she can change direction and look at it from all sides. And then she says, okay, that looks quite fine, but I think I would like to have it a little larger. Okay. And then we start to discuss. And there is a moment where I say, I can do this, but actually I tell you, it won't look very good. It will look very unnatural. Yeah. It's too heavy for your body. You will feel it when you move your arms.
Oh, really? Yeah. Because it's cutting out onto the side, hitting the arm.
Too far outside of the ledge. This is something that's quite often. If you have a small thorax, then it can happen that the implant is too far out. Interesting. And so these criteria, you must talk to the patient and convince the patient to keep it natural.
What if you have someone who is a relatively smaller patient, almost no breast tissue, and they do want to keep it natural, but the size of the implant is still much bigger than the size of the mammary gland tissue?
This is what I said. You cannot use this my ideal.
Yeah, so then you've got to adapt.
Then I have to increase.
And a lot of people won't know this, but people in our field obviously do. When you put something into the body, and I'm not just talking about implants now, I'm talking about dermal fillers as well. Yeah. The interaction between that object and your body, the way they touch, is very, very crucial for the immune system. In breast implants, or in dermal fillers, one of the best papers on this is Leschke 2004, 2004, if we're saying it properly. Mm-hmm. And he talked about that surface property and the immune exciting capability that certain dermal fillers have. In breast implants, we have different surface types. We can see smooth ones. We can see ones which are slightly rough a little bit.
Nano.
What are your thoughts on these two different ones? Have you used both? What's your experience?
I've used all three. Okay. I've used rough. Yeah. I used smooth. I used polyurethane, which is the worst from the surface. Yeah. And I used nanostructure. Okay. So, and this is also something that has changed over the years. We started with the smooth implants. Yeah. Then came the rough, the general textured implants. And we used them for 25 years, quite successfully. And then they found out that the adherence between the surface of the implant and the soft tissue, this capsule, this soft tissue capsule that is produced by the body,
almost like a granuloma.
Yes, but it's usually quite thin. Okay. And it's very tight. They are very tight connected. Yeah. And when women are going for sports, jogging is the worst, then there is a lot of movement.
A lot of friction.
And the tissue cannot get away from the surface of the implant, so the breast tissue is torn off of the capsule. Yeah. And then a second capsule starts
almost like a
growing.
protection mechanism.
Yes.
The body is trying to
So
do.
they have two capsules and two risks of capsular contraction.
Right.
So this is the reason why they developed the nanostructure.
Yeah.
With, as you said, slightly rough, but not as rough as the former ones.
Yeah.
So the ingrowth of the fibroblast is still there.
Yeah.
But so they have not one direction for contraction.
Yeah.
That keeps them from taking the implant in the close and make it hard.
Yeah.
But the moment there is some friction, they can move away.
Okay.
So this is the idea.
And so what is the texture that you most commonly use in your practice today?
Since 10 years, nano textures.
Nano. Okay. And you talked about for a second there that it can make the breast go hard.
Yes.
Is that common?
It's one of the most common complications you can have, and every woman has to know about capsular contraction.
Yeah.
There are different reasons. There are a lot of scientific research about capsular contractions, and the results are, well, you can reduce it, but you never can avoid it.
Right.
100% avoid it. It's impossible.
Okay.
Even with the best implants, even with the best technique, there is a risk of capsular contraction left.
Okay.
It can be that one of the most important things is that there is as little hematoma as possible. Yeah. Hematoma provokes a stronger capsule and more action of the fibroblast around the foreign body. Mm-hmm. And then the surface, of course, how the surface is, is it rough or is it smooth? Yeah. Although there are already, again, discussions about smooth surfaces, if it wouldn't be better to return back to the smooth surface implant.
That's what I thought.
Yeah. At least the really strongly textured implants getting less and less important in breast augmentation.
And do you find that since the start of your career to now, the lifespan of an implant has increased?
This is also something I have always treated different to others. Because the beginning, I had to tell my patients after 10 years, you have to change the implant. Because it's not safe anymore. And I've seen patients who had their implants, smooth implants from the 70s, since 40 years.
Wow.
Without any problem. And I say, why should I change this? It's perfectly settled. It's covered by soft tissue of the body. Nothing can happen. Why should I take this out and renew it? There is nothing in the lymph nodes, no illness, nothing. So I say to my patient, please come every second year to make an ultrasound exam.
See the ultrasound.
And if everything is okay, there is no reason. It doesn't matter if this is 8 years old, 18 years old, or 38 years old. If the implant is okay, leave it as it is. Sure. And I say this since 25 years, not since they started to give a lifelong guarantee. Because I think it was in the early 2000s. There was one company, they said, we give a lifelong guarantee on our implants. Wow. You don't have to change it after 10 years. And all of a sudden, a year or two later, all the other companies said the same. I don't think they changed anything in the production. They just give the guarantee. Because they've seen one does it, we have to do the same. And so they everything has changed, and people, women or patients, they dare to keep the implant for a longer time. And so we are now free. We can decide if is it necessary or not, but we don't have to say, now it's 10 years old, take it out and replace it.
So you're asking the question, not doing it automatically.
Yes.
Interesting. And what about, there are people who have breast augmentation surgery and they have a kind of implant rejection syndrome where mentally they have a lot of changes. Can you talk about that, what it is and what your thoughts on it are?
You mean breast implant illness? Absolutely. I explain I have to talk to my patients about it, of course, and I say it's a collection of symptoms that can be related to the breast implant in the last consequence. That means they have pain in the joints, they have change of the skin quality, they lose hair, they have dry eyes, they don't sleep very well, they have headaches. It's about 11 symptoms. Most of them are like this, like rheumatoid complex.
Yeah.
And if this is excluded and they still have the problems, you must think about the implant as a reason. And then the consequence is you must take out the implant and you must take out the capsule, the tissue around. In my opinion, I think for me the most logical cause is a kind of film of bacteria between the soft tissue of the body and the surface of the implant.
Okay.
And these bacteria, they don't cause an inflammation, a visible inflammation.
Yeah.
They cause a constant
immune system activation. Yeah, that's what I thought.
And I think this is, then if this is the cause, then you have to take out the implant.
Always like you said, like a rheumatoid, like an autoimmune reaction of change. Yeah, no, I think we're on the same page.
You cannot say that doesn't exist, but it's not that it's, there is a statistic that says that 50% of the patients after taking out the implant have the same problems going on.
Wow.
So then it's not the implant.
Yeah.
And this is very important. Keep the implant in mind, but first look at all the other problems.
Yeah.
The other causes for the problems.
Yeah.
Before you go this far, because for the woman, it's a huge change, a very negative experience. If you have to take out the implant and go back to the old breast they didn't like.
Yeah.
It's such
psychologically.
It's such an important part of the body for a woman.
Yeah.
You really have to be careful with this.
Yeah.
And so I know some doctors, they are specialized on breast implant illness.
Oh, wow.
And they say, I treat you, but you must take out all the capsular tissue you find. That's not so easy. You must scrape it from the ribs sometimes.
That's traumatic.
And it's very traumatic.
Yeah.
And if this is the right choice, I'm not so sure about.
Yeah.
But you must really be careful with this diagnosis and with the treatment.
Yeah, I mean, autoimmune, I think the changes we're seeing now in autoimmune conditions when we take out lectins in the diet, I will go on because I'm very obsessed with diet, as I'm sure you know.
Yeah.
I suspect it has something to do with that and the presentation of class 2 HLA antigens onto cell membrane surfaces. There's a Google thing if anyone wants to have a look, but we'll move because I will talk forever on autoimmune conditions if possible.
Good.
I want to ask you what brands you like to use. What have you used in the past? What is your personal experience? What have you liked using, not liked using in terms of implants?
Well, I started with a company that's now coming back to Europe.
Yeah.
They produce in Brazil.
Yeah.
It's Silimate.
Yeah.
They were together with the German company.
Okay.
Polytech. they have a Schwarz-Rot-Gold flag on the box, and they had a fight about European market, and so they departed, and Silimate wasn't anymore on the European market, but now they come back again.
Okay.
So this is a very, very old company that's very reliable.
Okay.
Then I went to a French company. It's Sebin.
Okay.
I was there for looking at the factory and how they produce the implants. It's quite exciting how much difference is between the
really
producing, how you can produce the implants, how much man work is in the
manual side.
Manual work is in the production of an implant.
Yeah.
And then switched to a Scottish company,
Okay.
Nagor.
Okay.
They are in Glasgow.
Yeah.
And now I'm with Motiva.
Okay.
They're from Costa Rica. So I'm traveling all over the world with my implants.
What is the one that you're using Motiva now?
Mm-hmm.
What is it about Motiva that you think is better than the ones you've used previously?
When they started, I think it's now 12 or 15 years ago, and they showed us their implants. There were some things that really came directly to my heart.
Yeah.
Something I was always concerned, which I didn't like with the other implants. For example, you have at the base of the implant, you have a patch.
Okay.
When the shell of the implant, the silicone shell, is produced in dipping the mold into a gel bath, and then let it dry. Dip it in again, let it dry, dip it in again 7 times. Okay. 7 to 8 times, depends on.
So it builds a layer.
It built 7 to 8 layers.
Okay.
And then you put it out, you take the mold out, or you take it off the shell from the mold, and then you have the hole where you have the stick where you you're holding the mold. And this stick, this hole is then closed with a patch.
Okay.
And usually this patch has a small rim.
Okay.
And I've seen so often that this rim sticked to the underlying surface.
Okay.
It was grown in, and the implant always moving around this very tight stuck area, and this is something where it breaks rather often.
Right.
If there is any break of the implant, it's very often it's on this patch.
Okay.
And Motiva came from the beginning with a very smooth patch, without any step, without any rim. So it was very smooth.
Yeah.
It was vulcanized and it's very smooth. This is number one. And then they said because of the new surface, this nano surface, you cannot have different shapes of the implant. You have to have a round shape.
Yeah.
You just change the way the gel is moving in the body.
The rheology of what's inside
determines
the shape.
Yes.
Not the packaging for round or teardrop.
Yes.
Very interesting.
And so if it's turning, it doesn't change the shape of the breast.
Yeah.
Which all the former ones did.
Yeah.
And this I had a bet with one of the company people.
Yeah.
Once I said I'm absolutely sure after 5 to 10 years we don't have any anatomically shaped implants anymore. They are all round.
Yeah.
Because these anatomic shaped implants, they are a problem.
Yeah.
It hasn't. I've lost the bet.
Oh, okay.
they still exist. But this was something that Motiva did different.
Yeah.
And this, I was convinced this is the right way to
Fine.
To do
and
it.
You've obviously been using it to great success now.
Yeah.
And it's interesting you talk about the gel because I was teaching in Switzerland recently, and I was with a company there distributing Motiva. They had them. I picked it up and I felt it, and underneath, very, very strong, and there's no connection, there's no stitching, anything like that. And what I did was I took the different implants and I held them vertically, and you can see the shape. But when you put it flat, they all look the same shape.
Right.
When you put them up, then they have a different shape. It's very clever, very, very clever.
Yeah.
And I think a mutual friend of ours has recently just got Motiva into China as well, so I'm sure it'll do very, very well. Now, talk to me about how long a typical breast augmentation surgery lasts, assuming there are no complications and everything goes according to plan.
So if I do a transaxillary implant augmentation, it takes a little longer.
Okay.
It takes between 40 and 50 minutes.
Wow, less than an hour?
Yes. And people are staying for one night
Yeah.
just to be sure that there is no bleeding or any complication. And then they go home.
Okay.
And they come back after a few days for lymphatic drainage.
Yeah.
After 10 days, a week to 10 days, I take off the tapes.
Okay.
And then they get a bra, and that's it.
And what about the submammary entry? How long does that operation take if you were to do that?
20 minutes or half an hour.
Wow. Incredible.
Yeah, but it doesn't matter.
Okay.
If it takes an hour, it takes an hour.
Yeah, as long as it's needed.
It's not a matter of quality. It's just it's routine. Yeah. And I think the difference isn't that important that it must be a criteria for a decision. You make the incision here or there.
I agree.
It's something you have the rest of your life.
Yeah.
So you must really think about it, not how long does it take or how much pain do I feel or can I lift the arm after a week or not.
Yeah. It's a small price to pay.
It's a very small price.
Great. What are the most common complications that you see in breast augmentation surgery today?
It's bleeding. Some hematoma can happen. Most of the time, it's not necessary to treat it.
Okay.
There can be a little wound healing problem, but usually you don't have to take
any medication or anything. Yeah. Okay, fine.
Then of course capsular contraction. At the beginning, there can be some numbness on the breast, but this usually disappears. And then there is, of course, the capsular contraction you must know about.
How long does the numbness normally last for?
But if there is one, it can disappear after 2 to 3 weeks. It can stay for 3 months.
Fine. I guess it's just
without being stressed.
Proximity to the nerves, and that's all it was. Fine.
Mm-hmm.
Now, another area of breast augmentation I want to talk to you about is breast augmentation in male patients transitioning in terms of gender to female patients in the transsexual community. I don't know what the technical term is now. Do you find that, or if you've done that type of surgery, do you find that is more difficult or more easy or completely the same?
No, it's more difficult.
Okay. What makes it more difficult?
You don't have any tissue. You have no breast tissue at the beginning. Sure. You have you must work with the muscle, and muscles are much stronger in male patients.
Yes.
You need the muscle. Either the only alternative you have is you put it under the gland.
Yeah.
Let's say under the subcutaneous tissue, and then inject fat. Make fat grafting to make it smooth. Okay. This is also a possibility.
Okay.
The ones I've done with submuscular.
Okay.
And the muscle was very strong. So it's really much more difficult.
Okay. The principle of where you place the instruments, that's the same?
Yeah.
Okay, fine. Interesting. And what about in the follow-up, in the longer term? Do they age differently in women versus men transitioning to becoming women?
No, they are almost the same. Yeah.
Fine. Now there's another type of surgery, another type of breast augmentation that I want to speak to you about, which not many people in the UK will have heard of, but it is available elsewhere. And I know that you were one of the key people involved in this process, which is Mia Femtech. Mm-hmm. Could you describe to our audience here what that is?
This is I think the best way to name it is it's not a breast augmentation, it's a breast enhancement.
Sure.
Because it's limited.
Okay.
It's limited to a certain shape of the breast and the body, and it's limited in the size.
Okay.
You use different kinds of implants. They are diamond shaped.
Okay.
Usually, if you put an implant on the table, it's flat.
Yeah.
On the bottom, and it's round shaped on the top.
Yeah.
These are diamond shaped.
Okay.
They have you can turn them upside down. There's no difference.
Right.
And they're limited to, I think, 190 to 200 cc's. That doesn't sound very much, but this diamond shape makes a really big difference.
Okay.
This 190 is a lot. Yeah. You really see a big difference. You see a nice improvement of the breast's volume. And the major change, you inject them.
Okay.
You make there is a special device where you make an incision in the axillary fold in the armpit. Then you always put it subglandular.
Okay.
Above the muscle.
Yeah.
And then you prepare with a special torque, you prepare a tunnel.
Yeah.
Then you insert a balloon
into that tunnel you've just made.
Into the tunnel, and with the balloon dissects the cavity.
Yeah.
And you take out the balloon, and then you suck in the implant in a kind of gun.
Okay, so it's like you're loading the gun with an implant.
Loading a gun with the implant.
Okay.
Put the gun into the tunnel, and you press the button, the trigger, and the implant. Poof.
So it's a quick implantation.
I did about 10 to 15 of these in 4 years ago.
Yeah.
When they started in Costa Rica.
Yeah.
I think it was one of the first in Europe and I operated about, I think, 10.
Yeah.
And at the end, it took me about 60 minutes in local anesthesia.
So when you place this implant, so you've made the fold, you've made the entry, the incision, you've made the tunnel inside.
Yeah.
You've put the implant in. How do you then inject the implant?
No, you have this balloon.
Yeah.
That dissects the layer between the gland and the muscle.
Yeah.
This is very soft. You can dissect. When I do a regular breast augmentation, you can do it with your fingers.
Yeah.
And then you have this cavity, and you just put the nozzle of the gun inside, and then it's air pressure.
Okay.
And air pressure pushes the implant inside.
So the implant is a fixed size. You don't inject the implant once it's inside to make it bigger.
The implant has a special size. It's very malleable. It's very soft.
Fine. Okay.
You can
then it
suck
just
it in
sucked in and it stays.
And this limits also the size of the implant.
Yeah, and how much of an improvement people can see. So I guess you can probably only go up maybe 1 cup size,
right,
in something like that.
And there was once they were interviewing me afterwards, and they said, "What do you think about this new kind of breast augmentation?" I said, "There's no breast augmentation."
Yeah.
And I think this is the most important thing. You must think in another way about this treatment.
Yeah.
As I said, breast enhancement, I think is the right word. There was once, I don't know how many years ago, there was from Qmid, there was a company in Sweden.
Yeah.
They produced Restylane. I think Restylane mostly
fillers. Yeah.
No, it's a filler, hyaluronic acid, and they produced a filler for the body.
Yeah.
It was Macrolane.
Yeah.
Called, and they showed how to make a breast augmentation with Macrolane.
Yeah.
No scar, very easy in local anesthesia. Treatment takes about 10 to 15 minutes. And so you have a slight improvement of your breast volume.
Yeah.
And this exactly for these patients who were then Macrolane patients, these are the patients for MIA system. Because it's not, if you want to have a regular breast augmentation, do a regular breast augmentation. If you want to have a improvement of the shape with not too much volume, then MIA.
That's for you. What do you think about nowadays some people talking about and advertising dermal fillers for the breast? It sounds like rubbish to me.
Macrolane was the one. Yeah,
that was the first one.
That was the first one, and they showed me Macrolane, and I was at the AMWC in Monaco.
Yeah,
and they showed me Macrolane, and I said, "Don't give this to anyone who is not capable of doing breast surgery."
I agree.
Never give this in a hand. Sorry, not of a dermatologist or a general practitioner.
I agree with you. Yeah.
Because if you don't put it on the right place, you will get a lot of problems. What they did workshops for this treatment. I did some too. And I was the one from Austria, this guy from Tirol.
This crazy guy.
Crazy guy. And I said, you must make a pocket like you do a breast augmentation and inject the filler in this pocket.
Yeah.
Nowhere else.
Yeah.
And there was a very nice man, a doctor from London. Please don't ask me the name. I can't remember it now. He had a few 4 or 5 clinics in London, and he injected it just as it is. And I said, I wouldn't do this. You must have a pocket. You must keep it on one place. Otherwise, you have cysts everywhere.
Yeah, exactly.
And that's what's happened in France. The French radiologist said, I cannot say, is this macrolane or is this a cyst? How does this tissue look like? And this is why it was banned in France, and then it was banned everywhere.
Yeah.
And this is the reason why I don't agree to use fillers in the breast. If you use a filler in the breast, you must put it in one place.
Yeah.
And not
wherever you want.
Distribute it all in the breast tissue, because then breast observation is almost impossible.
Yeah, I completely agree with you. I completely agree.
So, no.
Yeah.
Fillers, dermal fillers are not made for breast augmentation.
Yeah. Because, in this country, in the UK, anyone is allowed to inject dermal fillers, which is a discussion for another day. But regardless of that, just putting fillers anywhere you want something to be bigger is just ridiculous.
Yeah.
And there has to be an understanding of the anatomy. I think it's understandable that healthcare professionals, especially dentists, do it quite naturally in the head and neck, because we're specialists in the head and neck. That's what we did 5 years studying. But breasts, there's a reason plastic surgeons do that, and no one else.
And even for plastic surgeons, breast tissue is so delicate and so endangered. Breast cancer is the most common cancer in women. I think so. Statistics, I'm not absolutely sure. But it's one of the most important problems, or most common problems, and don't make it more difficult to find it in an early stage.
Yeah.
If you do this is something you're
really endangering the patient.
Yes, absolutely.
Yeah, agree.
Even a breast implant is already a hassle. Yeah, but you have possibilities to push the implant aside and look at the tissue. So this is okay.
Okay.
But injectables, they are everywhere.
Yeah, I say no. So I want to move on to facelifts, which I think probably facelift, neck lift, and breast implants probably I'm guessing the top 3 most commonly performed surgical procedures. Now, when a member of the public says facelift, they just think. But when a plastic surgeon says facelift, there's a smash lift, there's a deep plane lift, there are countless others. Could you give us an idea of the different types of facelift that are possible or available?
When I talk about facelift, I say there is no facelift.
Okay.
There are different techniques you can use to treat the change of tissue over the years.
Yeah.
So you have like a shelf full of different techniques. You look at your patient and you think about the possibilities you have.
Which one do I need
and
to
take the ones you need. And that's it. So for me, there is no facelift.
Okay.
I do a lot of endoscopic treatments in the face, because I divide an area where there is an excess of skin.
Okay.
And there is an area where it's just a looseness of the soft tissue.
Okay.
If there is only volume loss and loose soft tissue, you don't need to excise skin.
Okay.
Then you don't need to have a big scar.
Fine.
So, in the frontal area, brow lift, I never do it open. I always do it endoscopically.
Okay.
Mid-face, in my opinion, only volume and sagging, but no excessive skin. So why should I do an incision? Fine. But here, and especially on the neck, there is excessive skin. So here I have to treat it open.
Completely different technique, I guess.
Completely different technique.
Fine.
And then it depends. That is my most important saying, my most important word somebody said was from Illouz. He was French.
Okay.
He was one of the inventors of liposuction.
Wow.
In the 60s, 70s. And I met him, and he was a really interesting guy. But the word he said was, everything you do, think about, keep it simple.
Mm-hmm.
So you can go down to the bone. You can cut out pieces of your skull and put it in somewhere here. You can go deeper and deeper and lift everything up. Go to the midline, whatever. At the end, if the result is really so much better that this effort is necessary, then okay. But usually, the less trauma you put on the tissue, the better it is. Sure. And so I go sub-SMAS.
Yeah.
The SMAS, I don't know.
Connective tissue, yeah.
It's a connective.
So the SMAS, if people don't know, we have different layers in the face. And typically, depending on where you're talking about, you can consider it, to simplify it, as 5 layers. Skin at the top, bone on the bottom. And then just inside those, you've got fat layers, superficial fat or shallow fat, deep fat. And then you've got SMAS, submuscular aponeurotic system. This is a layer of connective tissue. It is what allows, when you make a facial expression with different muscles, it allows your face to move as one, as opposed to each individual part of the face moving in different timing. So the SMAS is what keeps everything together. So when Carlo is talking about a SMAS lift, he's talking about going down to this particular depth and lifting this particular layer.
Right.
Yeah.
So for me, this is the most important layer in the face for rejuvenation.
Okay.
And when I put tension on a part of these layers, it's only the SMAS.
Okay.
And then if you pull up the SMAS to the original position, the skin goes with it.
Yeah.
And then you just take away the excessive skin, but you put no traction on it.
Okay.
Otherwise, the scars aren't
fine. And sorry, go on.
So I go a little bit. I mobilize the skin.
Yeah.
Then I mobilize a little bit the SMAS as far as necessary, but not further.
Yeah.
And then I take I put some sutures to lift up the SMAS, and then I take away the SMAS.
And hold it in position.
Mm-hmm.
So when you're lifting the SMAS, we have true ligaments and false ligaments in the face. When you're pulling the SMAS, do you not get resistance from ligaments that go all the way down to the bone to pull against you and take away from the result that you've done?
Yes, and this is why I combine this treatment. I go as far as tension isn't too much.
Okay.
So I feel the resistance of
so
these
it's
ligaments.
based on what you're feeling in
I feel the
operation.
resistance, but I don't cut them.
Yeah.
I fill them up.
Okay.
Because we know since some years that it's not that they get loose. They lost the loss of volume.
Yeah.
Makes them
Sack.
relax. Yeah. So if I pull a little bit and fill a little bit, I have the best of both.
You got a little bit of pressure pushing out.
Yeah.
Could you give us an idea? After you mentioned the SMAS, which is not fully invasive because it's not deep plane, it's not going to the bone. Could you give us an idea of the sort of least and most invasive techniques that you have available to you when you're doing some kind of facelift for a patient? Yeah,
at least is of course when you just pull on the skin, which is not very successful because skin is always a very it's too elastic. It gives way. So you have some months or perhaps a few years. Depending on the quality of the skin, where you have an improvement, and then everything is going back again. Especially because the weight of the tissue underneath pulls it back again.
Sure.
So you need this SMAS to have a long-lasting effect.
Yeah.
If you go down to the bone, you go to these retaining ligaments, you really transport them to another place. You must somehow take care that they are get contact with the bone again.
Yeah.
So
they make that connection again.
Yes,
the grip.
Yeah. So this is a major difference between the techniques.
So for those that don't quite understand about the ligaments, if we think back to that diagram I mentally said, we've got skin and bone, fat and SMAS, the connective tissue. There are some ligaments in the face which go through all of them and go straight onto the bone. Not all of them do. Some only go to a certain distance down without being too complicated. What Carlo is saying is that if you take a ligament that goes all the way down to the bone and you lift the whole thing up, that ligament is firmly attached to the bone, okay? So if you're lifting that up and pushing it further up the face, it has to reattach and form that grip again in order to allow function in the face and for the ligaments to retain their function. That's what you're saying, right? So when you do these techniques, would you say that nowadays there is any particular type of complication that is more or less common regardless of technique in the facelift?
In my opinion, facelift is quite a safe treatment. Okay. It's has a bad reputation. Some people are very much afraid of a facelift, but especially because of the traction. If you see the strange plication of the skin because of too much traction on the skin,
like in some thread lifts, for instance.
Yes, right. Yeah. So I think this is one thing you must keep in mind, that there are. That you don't pull too much. Yeah, this is the thing. And then the more aggressive you work with the tissue, the more you must take care of facial nerves. Yeah, the great advantage is it's like a network. They are connected. There are different branches of the facial nerve, but more or less most of them are connected between each other. So. Yeah. It can recover without any treatment, even if you have for some time a weakness of a muscle. Sure. So this is one thing you must keep in mind. So it depends very much on the technique you're using. Yeah. And then it's the normal complications like hematoma.
Fine. Nothing specific.
Nothing. How do you say?
Earlobe.
The earlobe that is attached to the cheek is something where you see quite often that there was a facial treatment.
For those that don't know, facial nerve is cranial nerve number 7, and there's 5 branches. So we have the frontal, the zygomatic, the buccal, the marginal mandibular, and the cervical. These are crucial in facial expression. So what Carlo is saying is you have to understand the positioning of these nerves in order to minimize the complications to them. Now, correct me if I'm wrong on my anatomy, but in this region, in the mid and lower face, these important structures are sub-SMAS. And so when you are using a SMAS lift, I suspect the reason you see great success with little complication is because you're not going into the danger zones. Is that one of the reasons you prefer to go to the SMAS and not deeper?
Yes.
So.
Keep it simple.
Yeah.
And the facial nerve is between the gland. It's in the salivary, in the parotid. Parotid gland. It's in between 2 layers of the gland. So if you prepare off the SMAS, you're safe. When you're on the medial border of the gland, you must be careful because then you can see them. They are on the mesenteric muscle, so you can really observe them. Yeah. But there I don't use any scissors anymore. Okay. I just make a blunt ovalization.
Right. Fine. And I think actually that is why, just as a side note, why some people see nerve issues and salivary issues when Botox in the masseter goes wrong because they've injected it in the wrong position and it's now affecting the parotid gland and maybe the facial nerve as well. You talked about the earlobe. Sometimes there's a bit of not a complication, but just a side effect, shall we say. Yeah. Now that is, of course, to do with the incision that you use for these techniques. Could you give us an idea of the variety of positions where you can enter the face or make your incision?
Oh yes, that's a lot. The most common incision is in front of the tragus, around the earlobe, in this sulcus behind the ear, and then you go to the hair bearing area. Okay, more or less long, depends on how much skin you must take out. Yeah, I go behind the tragus. Okay, so I clear the tragus from skin.
Okay.
and then put the skin underneath. So I have the scar inside the ear. You don't see it in front.
Okay.
This is also a common procedure. It's nothing special from me. It's
fine.
There are doctors who do this and others do that.
Yeah.
Even I change, for example, in a male patient, I always go pre-tracheal.
Okay.
Never inside, because otherwise I have the beard growing inside the ear. And then how far you go up there are a lot of different opinions. I know a technique where you, for example, go straight up from behind the ear, straight up into the hair-bearing area, and you go in the frontal area up to the or in the hair-bearing area up to the frontal temporal area. I don't do this because this is an area where I use endoscope, so I don't need it. I stop here.
Fine.
I do a small back incision here so that the hair-bearing area is not lifted up.
Okay.
It stays where it is.
Okay.
So then especially, as I said, behind the ear, you can go along the border of the hair-bearing area. You can go inside the hair-bearing area. You can go straight up. So
okay, fine.
Nothing's right. It's just how you.
What is best for that patient?
Yes, yeah, absolutely.
That's interesting, because I've seen some terrible scarring going all the way across.
Yeah.
And would you say it's more common nowadays to not go across because of the reasons you've just said?
Yes. For me, this is something I do since more than 30 years. I do it only endoscopical.
Okay.
Because in my opinion, there are so many things going on up here.
Yeah.
It's not only the blood supply. That's not so important. It's very good, very well supplied with blood, so it doesn't change. But nerves are cut through.
Supraorbital.
They go straight up. And in my opinion, also the from acupuncture meridian is going up here. So if you cut through all this, you really have a trauma.
Okay.
And this is not worthwhile. You mobilize all this area under the endoscopic view with a small incision about, again, 2.5 to 3 centimeters in the temporal area.
Yeah.
Perhaps you touch one of the sensory nerves, and you have a numb feeling for a few weeks up here, but nothing else happens. Yeah. So this is, in my opinion, obsolete for me. It's obsolete to make a scar along the hair-bearing area or in the hair-bearing area only for lifting up the hair-bearing.
Because you have the endoscope.
Yes.
Could you explain to people who may not know what an endoscope is, what it actually is?
Endoscope is more or less it's a camera you put on a long tube, which has glass fiber inside. So the camera gives you on the monitor 4 times enlarged picture of the inner of the area where you are with the camera inside. You can look inside. You look on the monitor and work.
So you're looking over a screen, but your hands are down here almost.
Yeah,
like playing a video game almost.
Yeah, like playing a video game, right?
So you mainly use an endoscope for the upper face, but in the mid and lower face, you still use a sort of.
Not in the mid face. In my opinion, in the mid face is as I said, is like a volume and a sagging.
Yeah.
So you can lift this very nicely from up here.
Still with the endoscope.
Yeah.
Okay, so it just goes all the way down.
Yeah.
As long as it's long enough, and then you pull up essentially.
So endoscope is like this.
Okay. Wow. So very long. Very long. So if you were entering here, and you're trying to lift this particular place, how do you hold the tissues up? Because the endoscope is not stitching. Do you basically just pull everything and then...
I make a stab incision with a stronger needle here. Then I don't know how you say to this instrument. It has a very sharp tip.
Yeah.
And you can open it. It has a small like a needle you use for suturing.
Oh, right. Okay. Yes. Yeah.
And then I go in with a needle holder and a sling of the thread, and then I grab it with this sharp instrument, pull it back, and make a loop through the soft tissue, and pull it out back here.
Okay.
And when I pull here, it's lifting the tissue.
What's that made of?
The thread?
Yeah, is it just a sort of a standard Vicryl?
No, I use Gore-Tex.
Gore-Tex, okay.
Gore-Tex or Teflon.
Okay, fine. And do you find any issues with those materials at all? Because I know some people don't like the use of those materials. What is your opinion on that?
I think it's important to use a material that stays long enough in the body to really make a reaction that sticks the tissues and keeps them in place. In my opinion, for example, a Vicryl or absorbable suture that loses about 50% of the tension after 14 days.
It's good in dentistry,
short.
But not good in plastic surgery.
That's too short to keep the face in shape.
Okay.
So I need something that lasts longer.
Okay.
And then I prefer to use a very soft thread that is not too sharp on the tip. Like there are absorbable sutures you can use, like polylactic acid.
I was just about to ask you that. Yeah,
they stay for a year, but they are very tight, stiff, and this is not good for the movement.
Okay,
so I don't like them so much for facelift.
Okay,
I use Gore-Tex. It's fine. It's used also by vascular surgeons to suture the vessel, and they don't take it out as well. So
okay, fine.
Nothing happens.
So if someone wanted to lift the upper face, mid and lower together, you would then combine the endoscope technique that you talked about. You would combine the incisions here, whichever technique you wish, and you just do them all in the same day.
Yeah, absolutely.
Fine. And if you wanted to lift the jowl, which we mentioned earlier, what are different techniques you might use to try and lift this without looking too much like this?
Yeah, it depends on is there excess of skin or not.
Okay.
We said most of the time there is an excess of skin, then you must make the incision around there. And what is important is to imagine where is the vector where the soft tissue went down.
Yeah.
So in the midface, it's more or less vertical down.
Mm-hmm.
The further lateral you come and the further down you come, it turns to a more horizontal direction. So if you lift the jowl, you must go vertical.
Yeah.
If you lift the neck, you can go more horizontal. So
right.
this is how I treat it. This is also when you do thread lifts.
Exactly.
Many companies say you must do the thread lifts along the jawline.
Yeah.
In my opinion, that's the wrong way. You must go vertical.
From here.
Yes.
Okay.
Because the sagging down is also vertical.
What about entries maybe slightly in the hair? Mm-hmm. In this, so if the jowl is here, if you were entering here and you did a slight, not vertical, but a slight diagonal like that, what is your thought? That's okay.
That's fine.
Okay. Fine.
That's fine.
Now, what about patients who have that kind of mid and lower face lift? What do you think is your opinion on patients doing it, whether they're slightly overweight with maybe a slight excess amount of fat versus who are slightly skinny, where they almost look quite gaunt inside? Could you talk us through the difficulties of managing these kind of lifts for those kind of patients?
It's not, in my opinion, it's not difficult. Okay. It depends on what I'm doing. The thing is, if you have a lack of volume, you must replace the volume.
Sure.
If you have more sagging than volume loss, you do more lifting.
Fine.
If I do a facelift in a skinny patients, I always inject fat. I always use fat grafting in combination.
On the same day?
On the same day.
Okay.
In the same treatment.
Yeah.
So I try to go in both ways to make not to pull too much.
Yeah.
Only to compensate the lack of volume. This is
very similar to how I work. When a patient comes to me, say they're quite skinny in the face, and they need some lift, I might use a referral to a plastic surgeon to do the lift. They'll come back, and then we might use something like a thin dermal filler afterwards.
Absolutely.
And I think that's the best way. That's what I advise. And I think you said the perfect thing there.
I would even think about turning it the way around. First filler.
Yeah, you can do.
And then surgery.
Absolutely.
Because then you don't have to pull so much.
Yeah. I think a lot of people do have to be careful with that way around, not with filler, but with other treatments before surgery. I know there's a really great picture that Mark Pacifico, president of the British Association of Aesthetic Plastic Surgery, he took a picture during a procedure. He had the incision and he was standing behind looking into the patient, so the skin was open like this, and he could see inside the face. It was just scarring everywhere, and he couldn't do the facelift, I think, or he would struggle at the very least, from what I could see. That was because the patient had done a treatment called Sculptra before, which is, as we've mentioned already, polylactic acid.
Yeah.
And what are your thoughts on patients who have had this treatment, either at all or pre-plastic surgery? I'm assuming it's a nightmare.
We at the beginning, I already said we are working with scars.
Yes. Yeah.
Yeah. So in a moderate way,
Yeah.
I even agree to use polylactic acid as a filler, to provocate the fibroblasts to produce collagen type 1 and 2, type 1 and 3, but not exaggerate, not too often. Even if I treat, I have a patient who comes the second or third time for PLLA injection.
Yeah,
I feel the difference with the cannula.
Okay. Yeah,
absolutely. And this is also for surgery. Although I must say, you can do the surgery. You have a very strong scar to lift up.
Yeah.
It can be a problem if it's too deep that it's difficult to move the tissue. But on the other hand, for example, if I do a facelift, a second treatment after 10 or 15 years, it's most of the time it's even easier because you have already your layers, and you can put the sutures in the scar and have a good grab. And so it can happen that even if you have a treatment with PLLA before, it can be easier to grab the tissue. But if it's too much, everything that is too much is not good.
What I find when it's done too much, which unfortunately from what I've seen is a lot, most of the time it's too much, I think.
Yeah.
It just you can't differentiate the layers. It's just like a big ball of rubber. Like you can't even tell what is going on. I've looked at these patients who have had too much under ultrasound. I have no idea what I'm looking at, because it's just scarring everywhere.
Absolutely.
It's ridiculous.
Yeah.
Are there any other treatments that you advise patients to avoid if they're thinking of doing plastic surgery sometime, for examples like this where it makes it very difficult?
Yeah. Well, in a short term, I would never do a thread lift before an operation.
Sure.
I don't think that's really because it makes a surgeon difficult to find out how far you must go, and it's also for preparation. It can be in the way, but this is a year or so that then it's gone. Right. So mainly inflammation treatments like you said, like polylactic acid. Everything you fill in that lasts for a long time.
Calcium hydroxide.
Oh yes.
Yeah.
And the worst of all is PMMA.
Yeah.
Pooh. Then this I would never do. I would never do at all.
Well, yeah, I agree.
And not before surgery.
So for those that don't know what we've just spoken about, so PLLA is polylactic acid. PMMA is polymethyl methacrylate. Calcium hydroxide is something that's added to certain fillers. Sometimes you might get a filler where it's slimmed hyaluronic acid and calcium hydroxide. All of these work basically by irritating the tissue, by forming scar tissue. They're not working by increasing the physiology of the fibroblast cells or any other cells in the nearby area. They are irritating, poking, punching, prodding the cells, and they are defending themselves by laying down scar tissue. That's how these things work, sadly. But manufacturers don't like to say these things out loud. And so that's why it can make it more difficult for surgeons like Carlo, when it's done too much, to have these kind of effects in the skin or under the skin. In terms of the actual procedure itself, let's say, for instance, someone is wanting an upper facelift, so you're using the endoscope, and the mid face, for what we've said, and the lower face, what kind of time are you looking at for start to finish of the procedure?
It takes me about for an open, I say neck lift.
Okay.
It takes me about 2 hours.
Okay.
If I do a brow lift in general anesthesia, it takes me about 20 to 30 minutes.
Okay.
So mid face, another 10 to 15 minutes more. So altogether, it's about 3.5 hours.
Roughly. Okay. So far longer than a breast augmentation, of course.
Yes.
Even though you're not actually putting anything in there as well. Are there any advancements in facelifts over the recent years that have made you think, this has massively made my life easier, this is going to make results better, maybe in terms of instruments, new techniques, robots maybe?
I have no experience with robots.
Okay.
I love to work with my hands, so
okay.
I've never thought about this. But and especially facelift is such a delicate preparation. I finding these layers and dividing them and make it as clean and less traumatic as possible. Yeah. I think it's it's very fulfilling for me.
Yeah.
So I will never. I'm jealous for it if any robot is coming and doing my work. So this is not the thing. Techniques are changing a lot. As you said, as we talked about different layers, we started with on the skin, but it was in the 20th century, beginning of 20th century, where they started to cut out parts of the skin to make it a little, put some tension on the skin, and then smart lift for me was the most important step.
Yeah.
In technique. If you do a little or more preparation of the smiles, is very individual.
Okay.
It's very depending on the patient, depending on the surgeon, on his skills, on the risks he wants to go in or avoid. Depends. Yeah. So there is not so much difference in the techniques. Of course, all these endoscopic things, Renuvian, for example, is something that's quite new now, which is very interesting in tightening the skin underneath with coplasma. Renuvian is, I think, is this will also help a lot if the skin is very loose. Yeah. So and to diminish the amount of preparation. So this is something we must observe. And so there are always things coming and going. I used laser for preparation, CO2 laser for preparation. It takes ages to do the preparation. You're wrapped in a cloud of
vapor.
Tissue vapor. Yeah. So it's not really. It didn't bring this much advantage to conservative techniques. For example, in the Blepharoplasty, I only use the laser for cutting and for preparation.
Interesting,
but not in the face.
Fire. Do you think that there's such a thing as being too old or too young for a facelift?
No.
Okay.
No, it depends on how is the tissue, what's the problem, where is the looseness. Is it better to fill it up, or is it better to put it back where it has been?
Okay.
For example, in the upper face, if a patient between 25 and 35 is coming and saying, I have too much skin on my eyelids, then I always do a brow lift.
Fine.
Not a blepharoplasty, because they don't have excess skin on the lid.
It's
they have a sagging brow. Yeah. So the younger the patient is, the more I go into the brow lift than on the eye itself. And of course, I will. I don't treat patients with 25 or 30 years old doing a facelift. No,
sure.
But it's not. It's depending on the quality of the tissue, on the problem the patient has, not on the age.
Is there such a thing as skin quality being too bad for a facelift?
Yes. My oldest patient I did a facelift was 87, I think.
Okay.
But she had a good skin, so no problem. But if the skin is, for example, if they take steroids for a long time, so this is really, then the skin is really broken, and it's difficult to get a good result. Although you don't use the skin for pulling, but you must be very careful in preparation not to make any.
I think also the skin talks about how good the tissues underneath are. If the skin quality is poor, probably the strength of the ligaments and everything is not as good.
Absolutely.
And so if that kind of person came to you with very poor skin quality, would your treatment plan be to increase the quality of the skin for some time and then look at a surgery?
Right. This is exactly what I suggest.
Yep.
First, improve the quality of the skin.
Yeah.
Look at the volume, and then see what's left. Is it necessary? And even then, if there is an operation will be less invasive.
Yes.
Than when you start with the
Yeah. I mean, every single patient of mine, and I mean every single one that goes for any type of surgery. I speak to the plastic surgeon. I tell them, look, this is the referral. I'd like you to do this for the patient. We'll have a talk. But before they go, every single one I treat with Hasenohrl in that particular area. And the surgeons tell me their job is much, much easier.
Yeah.
And they will ask me for update pictures so they can keep it on their portfolio. And because when they come out of surgery, I do Hasenohrl straight away, they're healed in half the amount of time. And the surgeons are very, very much staggered and amazed at how we do that. So I think preparation is absolutely key.
I inject Hasenohrl at the end of the operation.
Oh, fantastic. So in terms of moving down from the face, also got the neck. I think the neck and the eyes are also very, very popular areas to get treated. Could you tell us what happens during a neck lift in terms of the anatomy? Where are you making your incision? Which direction do you pull in, etc.?
There are two incisions that are common when you do the neck.
Okay.
The smaller one is the incision underneath the chin.
Okay.
Submental incision.
Yeah.
Horizontally in most of the patients.
Yeah.
And then you can prepare the borders of the platysma, take out excessive fat even underneath the platysma, which is very important if you have too much excessive fat.
Yeah.
The submental fat, the subplatysmal fat, is most of the time it's a problem when you have patients have a liposuction and don't see very much difference.
Yeah.
Then it's then you must prepare. You cannot suck this out. You must prepare it.
Okay.
Take it out. Okay. Surgical. So this is a very easy treatment. It's done under local anesthesia in a rather short time. Even sometimes I use a vertical incision in the midline. If it's an old patient who doesn't want to have a large operation, or male patients, they don't want to have a scar around the ear. So I take out some tissue here, some skin, make a zigzag scar to improve it, then suture the platysma and close the skin. Okay. Makes a very nice angle here.
Okay.
And most of the time I do the incision as I explained around the ear.
Yeah.
Behind the tragus and around the earlobe. And then prepare the skin, pull on the platysma tight, and then close the skin. So for me, the neck from surgical point of view ends here in the corner of the mouth,
because the
not
platysma
here.
goes
Because it's platysma. This is the area where the platysma changes to the smas.
Yeah.
So if you want to lift the neck, you must also for lifting the jawline, you must go up here.
Fine.
So you do that.
I agree. For those that don't know what Carlo means by platysma, this is a sheet of muscle that we have over our neck here. And it does go over the jawline. Sometimes when you see a Botox treatment called a Nefertiti neck lift, you are going along the jawline. You're treating the platysmal attachment onto the face over here. and it can go above the jawline. And studies have shown actually the platysma, when it joins into this mass, it can even have connections that go all the way up here and into the eye muscle, which is called the orbicularis oculi. Actually, Carlo nodding as well, so I'm sure he's seen the same thing. And so it's all one complex. I know we say neck is here, but as far as nature is concerned, there's no hard definition of where the neck starts and ends. And I guess that's a bit of a difficult job for you sometimes to know where to make the end of the incision.
Yeah, it is exactly as you said. There is no clear border.
Yeah.
So you always treat a little bit the cheeks, even if you concentrate on the neck, it doesn't end on the jawline. You must go into the face. Otherwise, it's not complete.
Yeah. And I guess in terms of the two techniques that you've mentioned here, where you go around here versus when you go in the midline, I guess the advantage of going in the midline is that you can address some of the preplatysmal and submental fat in that region. But I guess you can't with this, or is there a way to do it?
No, you need this extra small incision from here.
Okay.
Yeah.
So what if someone wants to try and lift, but also remove some of the fat at the same time? Maybe they have a double chin, they want to get rid of something. Can you do this and this together?
Yes, absolutely.
On the same day?
Yes.
Oh, fantastic. And in terms of because I know some people have quite a lot of sagginess in that skin, in the neck. Is there a limit to how much you can take out in terms of excess skin?
Yes, of course, there is a limit. Due to the scar, how far you go, because the more skin you remove, the longer the scar is. But if the patient has a realistic expectation of the result, and you tell the patient that, okay, it will be an improvement, it will not be the perfect tight shape, because then I have to be too aggressive, then usually the patients are very fine. You will make a big difference. You really can take a lot of skin here.
Yeah.
Take away a lot of skin.
Okay.
But of course there are limits.
Okay. And when you do this, is it something that you commonly do with a lower face at the same time because of what we've just talked about?
Yes, absolutely.
So sometimes when you do a neck lift, then you get an improvement in the neck and the jawline.
Yes, you must.
Together.
In my opinion, this is the same. From my
I
surgical point of view, it's one piece.
Fine.
Neck goes up to the corner of the mouth at least.
Yeah. And could you mentioned in the midline, there are some different techniques that you use. Could you talk us through a little bit more detail about what different things you can do here? So obviously you can try and close it together tighter. You can remove some of the fat. You can try and lift the skin so it goes back in. Yeah. What other kind of things can we achieve in this region here?
Yeah, you must be careful with the scar. Yeah.
Right.
Usually you do the incision horizontally just underneath the chin.
Yeah.
And then you cannot remove skin. Usually you don't have to remove skin.
Okay.
Because when the skin is loose, it has the shortest line from here to here.
Yeah.
Direct line. The moment you tighten the platysma, it has to go up here.
Yeah.
Has an angle.
Fine.
So this is longer.
Yeah.
So makes no sense to remove a lot of skin. You must replace it.
Okay.
And you do this in suturing the platysma together, so there is enough tension because the platysma holds the skin in place, and when the platysma is loose, the skin is loose.
Yeah.
So this is the most important thing. So usually I don't remove skin at all.
In the middle,
except it's really a lot of skin, and you are not planning to make an incision around the ear, then you can remove the skin directly here, and then tighten it here. And this is I had patients who were rather old or not so interested in the jawline. It's more this double chin and the excess of skin down here. Then you can do this, but they have a scar then here.
Okay, down in the midline. Okay.
That.
And what about in terms of the important anatomical structures? What are the safety margins that you have to know about because obviously we have very important things here like the carotid artery. What are the kind of important things that you're trying to avoid? I can think of the thyroid as well.
Yes, you must be careful when you go underneath the platysma. The platysma is like a shield; it covers everything.
Fine.
It divides in the middle. At the beginning, it's in young patients, it's very close together. The borders of the left and right platysma is very close together, and over the years, it divides to the side, and you can see these lines on here.
Yeah.
And then it's under stress. It tries to compensate and contracts, and then makes these lines, and then you put them together again. But if you go subplatysmal, you're close to the muscles of the tongue and the mouth, so you must be careful not to harm them.
Yeah.
And then for swallowing, it's very important.
Of course.
And then, of course, the thyroid, when it's enlarged, for example, you're very close to this, but usually you see it very well.
Okay.
And there are a lot of vessels and a lot of small nerves, mainly,
of course,
sensitive nerves. So it's not so dangerous that you get a paralysis or something like that.
Yeah.
But anyway, you have to preserve whatever you can.
Yeah. Fine. So, and I guess even the important vessels here, they're all deep to the platysma.
Yes.
And so even if you're entering here and you're pulling up, it's not number as long as you're in the right depth, superficial, high up.
You see, when I do the incision around the earlobe, and I prepare on this mass and then the platysma too. Yeah. Down here, I can see the vein, the superficial vein.
Yeah.
Here.
And then you just know where to avoid.
Yeah.
Okay. And when you see visually, once you're inside the incision, what does it look like where the platysma meets the SMAS?
It's very difficult to find the it's not a line.
Thought so.
It's fibers going into the tissue.
Yeah.
It's very unclear. You don't see really a border.
Okay.
It goes smoothly into each other.
Okay. And when you're treating this area in the middle, and skin laxity is not an issue, but the amount of fat is an issue, how do you go about treating that?
Number one is liposuction.
Sure.
Of course, you can do some lipolysis injection.
Yeah.
You even can do cryolipolysis if it's not very much. But usually you end up with liposuction. It's in local anesthesia with a small stab incision. You don't see any scar. But if you find out that it's too deep, if it's subplatysmal, you can see it either with ultrasound, or you can even grab it. Then you have to make the incision here and really prepare
and pull it out almost.
Yeah.
And when you're going across the jawline here, from above to below, we have, I mentioned before about the facial nerve, we have the marginal mandibular nerve and the cervical nerve. What are the best techniques that you use to make sure that you avoid those?
Blunt technique.
Okay.
Yeah, as far as you can go. If you the first layer, lifting the skin from in this area, the skin is very tight to the fascia, and so there you must go sharp. But you're even above the auricularis magnus nerve, the sensory nerve for the ear, and this is a quite thick nerve. You see it very well. But then when you go out down here, as long as you're above the SMAS, it's no problem at all. You can really prepare easily. And even the moment you get underneath the SMAS, you must put away the scissors and make it blunt.
So you kind of wait until you feel through the difficult.
I incise the SMAS and the platysma sharply. And then I lift it up, and then I use another instrument that is bluntly separating these. And this is very easy. It's very soft, so it's easy to separate it.
Okay, I see. And in terms of safety, would you say with those techniques, it's a relatively safe treatment?
It's really a safe treatment.
Okay.
Yeah.
Fine.
The safest, the most important thing that doctor knows what he's doing.
Yes.
And I must admit, I also cut the nerve through. I've cut the marginal mandibular nerve once, but I've seen it, and I sutured it.
Okay,
and the patient didn't even realize.
Okay.
She had a weakness in the mouth, angle of the mouth for some time, but she thought it's because of swelling, and then it
just self-corrected.
Mm-hmm.
When you have those sorts of injuries, when you have nervous injuries, I'm told that in certain countries, what they teach is, let's take an example. Let's take you're removing a wisdom tooth, a third molar. We have the inferior alveolar nerve coming down here. Sometimes the nerve is here and the roots of the tooth are touching the nerve. Yes. And when you pull the tooth out, you damage the nerve. Mm-hmm. And in some countries, what they teach is to immediately refer the patient for acupuncture to the area and the nerve repairs itself. Have you heard of that? Is that something you've tried?
No, but I would do everything because you cannot repair it. You cannot look for it and suture it together like when it's more superficial because it goes inside the bone. Yeah. So no chance for a surgeon. You can, whatever helps is good.
Okay.
So if acupuncture helps, I think acupuncture is a good tool for us. So if it helps, then it's fine.
Yeah.
Fine. But I have no experience.
Okay. Interesting. I want to move to eye surgery or blepharoplasty as well. Lots of people, I think age first in the eyes because partly the skin is probably I would say the thinnest skin in the whole body.
Absolutely.
Is where the eyes are. And depending on which scientific paper you read, it can be as thin as 0.1 millimeters, which is why I think even non-surgical treatment is so difficult, even for things like skin injectables, dermal fillers, toxins, as well as obviously the surgical side too. I wanted to start, if we could, by describing what is actually physically there in the anatomy, because a lot of the times you will see a patient, if I just take my glasses off for a second, you will see, a line that comes down here and then another line that comes down here. Could you explain to people the anatomy that's going on there in terms of the orbital retaining ligament and the zygomatico cutaneous, the zygomatical retaining ligament that's going on there?
Yeah, for eye surgery, this area is a major topic.
Yeah.
We have to, you said orbital retaining ligament and zygomatic. These are two different areas.
Yes.
You have the upper blepharoplasty when you treat it surgically and the lower blepharoplasty. And this is so completely different in treatment.
Really?
Because on the upper blepharoplasty, you have two elements you have to look at. That's the excess of skin because of movement, because of environmental impacts like sun or dry air and things like that, and the sagging of the eyebrow. This causes blepharochalasis, excess of skin on the upper eyelid. So if you treat this, you must treat the eyebrow and the excess of skin or the excess of skin in the upper eyelid. Mm-hmm. So this is very easy. You excise the skin, you excise a little bit of the muscle, of the auricularis muscle, because this loosens with the skin.
Okay.
It take perhaps out a little bit of the intraorbital fat. It makes, especially in the inner eye. No. It's intraorbital. It's
intraorbital, right? Okay, yeah.
The eyeball is in a pillar of fat, so they can move in this bone cavity without friction.
Yeah.
And this fat can protrude.
Yeah, especially in the lower.
Especially in the lower, but even in here. Yeah. So I have to remove this excessive
Is that common?
fat. This is common, yes. Okay. And then you suture the wound together, and then everything is fine. The lower lid is much more complicated because, as you said, there is this teardrop. There can be two. Is referring to the ligaments, keeping this more or less making a border between these two indentations. And what is there so important is, why is there excess of fat? Why is there excess of skin? most of the time it's because the ligament holding the eyelid in position, as there are two in the inner corner of the eye, and there is one on the outer corner of the eye. And this outer ligament is very often loose, getting loose. So when you look at a young woman, the axis between the inner corner of the eye and the outer corner of the eye is slightly going upward.
Yeah.
From inside to outside. And in over the years, it goes down because this ligament is getting looser and looser. And when this ligament is getting looser, the skin is getting looser. And when the skin and the small membrane keeping the fat into the eye cavity is getting looser, then the fatty tissue protrudes outside, and then it's sagging. The tissue on the cheek, on the malar area, is sagging down and showing the rim where this membrane is attached to the bone.
Yeah,
it's the rim of the orbital. It's the orbital rim, and then you get this deficit. You get this loss of volume there, and the teardrop.
Yeah.
So what I do when I treat the lower lid, in 95 to 99% of my patients, I don't excise skin.
Really?
No. I lift up, I shorten the ligament, lift up the lateral corner of the eye, then there is no excessive skin anymore.
Okay.
And then I take out the fatty tissue from the inside of the eye, from the transconjunctival incision.
Voluntary, yeah.
Yeah. Take a little bit out, and the rest of the fatty tissue, I make a pocket underneath the teardrop and put the tissue in there, and keep it with 2 sutures in place.
Oh.
And then you have live tissue with blood perfusion.
Yeah.
In this deficit where the volume is missing, and less excess volume in the lower lid.
Interesting. So could you talk us through the incision points where you actually enter the skin with your scalpel?
So the on the upper lid, it's I excise some skin.
So all the way across.
All the way across in the first rim.
Yeah.
In the first plication fold above the eyelashes.
And how far lateral do you take the incision?
Not very far, because I always lift up the eyebrow.
Okay.
I go from the where I excise the skin. There's a defect. I go underneath the eyebrow.
Yeah.
Take the eyebrow with a suture from inside and put it on a very tense tissue about the orbital ligament, and make a suture there, so it lifts it up. And when I lift this up, there is not so much excessive skin on the upper eyelid, so I don't have to go far out. Okay. It stops here on the lateral angle of the eyelid.
So you're going from the medial canthus to probably about there, maximum, and then about here.
Yeah.
And then here is where you're internally putting the suture.
Right.
And which direction do you like to put tension in that suture?
I look where I have the most movement.
Yeah.
Mostly it's like this.
Yeah.
And I just push it up like this.
Okay, fine. And when you push up and the suture is going in this direction, how high up do you go with that suture?
No, it's directly underneath the eye. When you lie back, your eyebrow.
How high up do you tie it?
No, when you lie on your back, I do the operation in a prone position.
Yeah.
Flat, and then the eyebrow moves up by itself.
You just hold it in that position.
And hold it in this position, not further.
Fine. I understand.
Few millimeters.
I understand. And when you look at people who do what we call fox eye thread lifts in that area, personally, I think it's far riskier than people think. If you don't know already, you could theoretically at least, and I have seen it in person, completely sever the nerve which controls movement in this area. You could sever the frontal branch of the facial nerve, which just gives you that permanently. Could you talk about what techniques you use to make sure you're in the right layer when you're going into tie that suture?
I go in the roof.
Okay.
This is this fat tissue underneath the eyebrow.
Yeah.
So I'm safe there.
Yeah.
I don't go too far lateral.
Yeah.
This is very important because here it's dangerous.
Yeah.
In the lateral rim of the bony rim area.
Yeah.
There must be careful in the lateral part. But up here it's safe.
Okay.
And I take some of the ligament or the roof and then fix it in the deep.
When Carlo says roof, by the way, we're not talking about the bit that's on top. Roof is ROOF, retroorbicularis oculi fat pad, if you would like to Google. So could you talk a little bit also about Pitanguy's line and how that is relevant to finding that danger point, the frontal branch of the facial nerve?
Yeah, it's your Dabert. I'm not so sure about the Pitanguy's line.
That's fine.
I know that in the medial third between the eyebrow the eyebrow, lateral border of the eyebrow and the tragus, there is the nerve is in a superficial layer.
Fine.
I'm careful when I do, especially it's endangered when I go to mid-face.
Yes.
Endoscopical, I cross it. And I go either very close to the orbital rim.
Yeah.
And go down there.
Okay.
So I'm quite safe.
Okay.
Or I have to take care to be deep enough to be underneath there.
So if you're going in, so if you split this into thirds, so the medial third here, you're saying the frontal branch of the facial nerve is more superficial here.
Yes, here.
So you want to be deep.
Yes.
But if you are coming from above, coming here, I guess you don't need to worry.
Oh.
Okay, fine. Interesting. And then in terms of the lower eye, the lower blepharoplasty, could you talk about what variation there is in incision points for that as well?
Yeah, the general treatment is an open treatment.
What does that mean?
That means that you make an incision in just underneath the eyelashes. There is a small wrinkle there usually, and in this wrinkle you do your incision. Then you prepare either skin from the muscle and then prepare the muscle, or you prepare skin and muscle in one block. This is also both are techniques that are common, and then you lift or you take away the excess of skin.
Yeah.
Sometimes also a little bit of the muscle. Pull the muscle to the lateral to give it an uplift, and then make a suture there, and then close.
What's the most amount of skin that you could realistically take without looking stupid?
This is the point. It's in my opinion, it's 1 to 2 millimeters.
Yeah, I thought
so it's not worthwhile.
Yeah.
When you do a cantopexy, what I said with this ligament from the side, and you lift this for 1 millimeter, there is no skin left.
Yeah.
So this is why I avoid this incision as often as I can.
Yeah.
There are only very few patients with a lot of excess of skin where I make it open. Usually I always make it from the conjunctiva.
And another thing I want to touch on in this particular area is the bad results that we often see with using dermal fillers in this area, because they can last a long time. They can expand over time. They can move over time. MRI studies now are being done to look at that. Do you find that a lot of patients are coming to you for surgery in this area for the eyes because they don't like the results of fillers?
Yes, I have a amount of patients who had fillers and were not happy with the results. I have quite a lot of patients who have an excess of filler. It's not really an excess, in my opinion. It's edema that is there. And honestly said, I'm treating patients with fillers since Restylane is on the market, which was the first hyaluronic acid fillers. I started with collagen as filler when there was no hyaluronic acid on the market. So I did a lot of patients treated with fillers, but I stopped using a filler in the teardrop. I don't use it anymore.
Okay.
I do a regenerative treatment with Sonakis, for example, which I think is much, much better. I try to fill the in the deep layer here, the cheekbone, but not in this teardrop. And I think it works very nicely. It's good results. Don't have these problems with Tyndall effect or this bluish color here or swelling.
And could you explain to people how you treat a patient who comes to you with filler already? Let's say it's either too much or they've got edema and swelling and it's coming too much. How do you plan a surgery with something like that?
First, I try to get rid of the edema.
Yeah.
That means I use hyaluronidase.
Yeah.
And try to go back to the point of origin where it started.
Yeah. Pre-filler.
Pre-filler, and then think about surgery.
Okay.
Working with a complication, doing a surgery when there is a complication in this area is really, really critical.
Yeah.
I wouldn't do this.
Agree. Yeah. And in terms of the appearance that patients come to you with this, to us, we know the difference, but some members of the public won't. Could you explain the difference between a tear trough and an eye bag?
Yeah, absolutely. It's eye bag is excessive fat coming out of the orbital cavity. So the bony
coming out.
The bony cavity where the eyeball is inside the eyeball is in a pillar of fat to move in every direction, and there is this very thin layer of tissue, a septum, between the fat from inside the eyeball and the skin. And when this tissue gets loose, then the fat tissue pushes outside, and then you have these eye bags. It's important to make a difference between the eye bags and the lid and these malar bags here. They are on the bone, and this is completely different area. It's much more difficult to treat these malar bags here than to treat the eye bags.
Yeah.
And the teardrop and the orbital rim is as I said, it's like a volume in this area, and this is the point where this gentle tissue, the septum, is attached to the bone, and that is the only tense place. Mm-hmm. And there is also this a small ligament that keeps it in place. So when there is a lack of volume, you must replace it.
Could you talk about what it is that allows weakness in the ligament to give an eye bag such that the fat pushes through?
The ways.
What is it that allows or causes the fat to push through forward?
In my opinion, two causes. One is that there is a genetical factor that this tissue and this septum gets loose. You see it. Most of my patients come and say, "Oh, I've seen my mother with eye bags like this, and I don't want to come in this to this point. So please do something." And the second point is this ligament, this canthal ligament, this where the lateral corner of the eye is attached to the bony rim. Yeah. When this gets loose, then there is not enough tension on this septum, and then pushes it.
Okay, fine.
Fat can push out.
Interesting. Now, I want to move on to things about surgery in general, because I could sit here and talk for another 10 hours with you. I think what we'll have to do is bring you back maybe in a few months' time and do part 2. Because there's the other thing I would love to talk to you about. But I want to do the last section of this podcast talking about what you see in terms of the near future, in terms of advancements, improvements, trends or changes in the world of plastic surgery. We both go to a lot of conferences in the world. We read scientific papers, we talk about new techniques. Do you see anything new and innovative coming in the near future for plastic surgery?
What I see, what makes me very optimistic is that plastic surgeons aren't so much. In former times, they've been very critical to conservative treatments.
Okay.
Using an injectable was the worst.
The devil.
Just okay. That's just okay. But thread lifts, for example, never ever. And I find out that they see that there are so many conservative treatments that help you for surgery that diminish the intensity of a surgical intervention. So you can really give the best to the patient in treating them in two ways, in a conservative way and in a surgical way. Yeah. And we have all these tools in our hand. And I see that doctors are more and more finding out that it's not black and white. But there is a lot of different techniques leading to the same or similar effect, but there are limits on one side and there are limits on the other side. And if you see these and combine these two, you're in a superposition. You can make the best of both worlds. Yeah. And this is something. Of course, there are always coming new machines, new treatments, new radio frequency, plasma, new lasers. But I've seen that you must really look at what's the result and what's the effort, what's the risks, what is the risk of the treatment, and what can the patient expect, and what is the long-term effect. Yeah. And I just think about ultrasound in treating fat tissue. It was the one and only for some times. Yeah. You used ultrasound probes you put inside, and the ultrasound was destroying the fat tissue. Yeah. But it was such a thermal impact on the tissue. You made so much, such a lesion around this
destruction.
That the long-term effects were not. They people had a lot of problems with it afterwards. So this disappeared again, and this is so important that you have a very clear look at what's new and what is just good for social media and what is really good for the patient.
Agree. And I think that goes not just for the surgical world, but the non-surgical world as well.
Absolutely.
Treatments are made to look good on social media a lot of the time, in my opinion. And there's very few treatments that stand the test of time. Mm-hmm. And it doesn't make sense to work in trends because we're treating human physiology at the end of the day. Human physiology has not changed from last year to now, or from last 10 years to now, or from the last 100 years to now. So you don't need to jump from one trend to another. Our cells are still working the same way. And I think I was going to ask you about what you thought about robots performing surgery, but I think you mentioned it earlier. They don't have the ability to feel what is actually going on. And so are you under the impression, or are you on the view that there will be no place for robots in cosmetic surgery?
There is already a place, for example, in hair.
Yes, hair reconstruction. But I mean in terms of the treatments we've talked about today, in those ones.
For me, I don't see any realistic. There will be, for example, find the right depth for
the right amount of tension, the right position. Yeah.
But is it really, at the end, it's so important that you have the feeling, the skill. You find out what is good for the patient. How far can you go without making something worse instead of making it better? And I'm not convinced that a robot will ever be able to do this.
I think I agree with you. I think robots are useful in certain situations, for example, like identifying structures, for doing simply manual mechanical work. But when it comes to the concept of beauty, you can't even program that into a computer. You can program mathematical things like symmetry and size and mathematical ratios, but everyone has a degree of asymmetry. And how do you decide which asymmetry is more beautiful than another?
Yeah.
And I don't think we will ever replicate that with the machines.
Robots have no idea of beauty.
Exactly. So I think in situations like the hair transplant that you said, where it can identify the follicle, it can reach a particular depth, it can extract, follicular unit extraction, all these sort of things. Like, I get that, but not in what we do, I think. So yeah, I agree. What advice would you give for someone who is considering plastic surgery for the first time, if any?
Listen to the doctor.
Yeah.
Don't go there with a distinct treatment you want to have. Tell him what is your problem.
Yeah. What
do you want to have changed?
Yeah.
Not what he should treat.
Yeah.
And listen to him carefully. Listen how he's explaining what he wants to do, why he wants to do it. He must have a logical idea why he is suggesting to make this treatment, and what are the risks. He must be honest. When he's honest, and when he's you get the feeling that he's talking about it and giving you an idea what he's doing without hesitation, and not without let me do anyway, you're more or less too stupid to know what I'm talking about, then it's the wrong one. So everything is explainable. You really can go through all the steps with the patient and let him talk and let him tell you what he wants to do and why he wants to do, and then you get the right feeling and you can be safe.
So I guess the best way to choose the right surgeon is to see if they talk about those risks and they talk about all those other things.
Yes.
Are there any other tips that you have on being able to choose the right surgeon?
Yeah, perhaps you don't go to one because it's recommended from somebody you know.
Okay.
Look at different opinions, not too much. Sooner or later, you don't know what to do because there are so many, but you must know that he's really a plastic surgeon. Sorry, when I say this, especially in surgery, I think it's important that you know that he's the right training for plastic surgery, and then 2 or 3 opinions from other surgeons, I think is not a mistake.
Okay, fine. So a couple of different consultations, and I guess see which person you connect with and relate with the most.
Absolutely.
Those sorts of things.
In the end, it's a matter of human well-being, that you feel comfortable.
Okay, fine. And in terms of the treatments we've talked about today, so breast augmentation, facelifting, depending on which part of the face, neck and jawline lifting, and blepharoplasty. Could you give us, in euros, what a range we're talking about? So an expensive city like, say, Zurich versus a very cheap city, maybe in some part of rural France or something like that. Could you give us a range of what we're looking at for those kind of procedures nowadays?
Well, can I say it in euros?
Yeah, please. Yeah, do it in euros. Yeah.
Sorry. Well, I would say breast augmentation. If it's under less than about 4,500 to 5,000, then it's mostly something is wrong.
Okay.
So it's 5,000 to up to 8,000-9,000 is normal.
Okay.
My treatments, breast augmentation depends on the technique I'm using, is between 6.5 and 8.
Okay.
Then neck lift or open facelift is between 7 to 9,000 euros.
Okay.
I do endoscopical brow lifts in a range of 4,000. So this is I think this is a good average. It's not the cheapest, but it's not the most expensive. So.
Fine. And if you were going to do an incision here for a mid and lower face as well, what typical range would you look at for something?
Yeah, if I do the open approach from here to the neck and the middle face, then it's about 9,000.
Okay, 9,000, fine. And when patients pay for these procedures, obviously they get the procedure, but what about aftercare? What would you say is a typical aftercare period? I mean, you keep them in for 24 hours so you can watch them, and then you bring them back 2 days later to have a look as well. What would you say patients should look for in terms of aftercare minimum?
Well, first of all, I think it's very important that the doctor himself takes care.
Okay.
Not every check, but for example, for taking out the sutures, at least have a look at it. Yeah. I do it myself. I don't want to have anybody taking out the suture except I'm on a meeting or something, and I'm really not in town. But usually I do take out all the sutures I've done by myself, and then I can just talk from myself.
Yeah.
In this price I've told you, there are at least 3 lymphatic drainages included. There is the stay for one night included, and all my all my control visits up to a year.
Okay.
So in the first year, it's all included. If there is a complication, and if it's not really if there is, for example, a bleeding in the first 24 hours, nobody ask for any extra money. Yeah. We are all here. Yeah. We are all on duty, so it will be treated, and that's it.
Perfect.
If there is, for example, there is an asymmetry of the implant, and you have to bring it in the right position.
Yeah.
There is an anesthetist who needs a reduced
dose.
Then the nurse and the material, but I don't get any money for it.
Okay.
So this is how we treat it.
Okay.
And I think it's important that you don't see the doctor anymore after the treatment. He must be here. He must be here for you.
Okay.
This, I think, is a major thing. And then at least change of dressing and taking out the sutures is doctors.
Are there any particular brands used in any of the treatments that we've spoken about today that you would specifically advise patients to avoid?
Not really avoid. It's for example, when we talk about breast implant, I don't think that, for example, that this is thin ice.
Well, you don't have to answer. You don't have to answer. So it's entirely up to you.
There is an implant that is very firm, and they say it's very light. It's in the name also, and because there are small air bubbles inside. And I've used it several times, and I think it's awful. It gives a very unnatural feeling. Okay. So I wouldn't suggest this.
Fine.
Because it's the argument they use it is that it's lighter. It's about 30% lighter than the regular implant. But I used it, and the patient said it's so firm that they didn't feel...
Doesn't feel natural.
Yeah.
And in terms of the treatments we've spoken about, are there any particular techniques that you think people should just completely avoid at all?
No. It depends very much on the
Fine. So treat them as an individual.
Yes. I use radio frequency for reducing the fat on the belly.
Sure.
I think it's quite nice, but I have not very good experiences with radio frequency for tightening the skin.
Fine.
for
Fine.
example.
Okay.
But I know there are a lot of colleagues who are using radio frequency
Yeah.
for tightening the skin. I have no good
No,
experience.
I don't think it's that great nowadays. There's
Yeah.
better things in the market. Could you give us a little bit of detail on where your clinic is, the name, because I'm sure a lot of people would be happy to fly and see you. How do they get in touch with your clinic?
It's really easy. It's the House of Excellent Beauty.
Okay.
It's situated in Innsbruck, in Tyrol, in Austria. And we're a clinic with all devices we need. We have including me, 6 plastic surgeons in place. There is a dermatologist, a gynecologist, internal medicine, and we have also medical cosmetics. We have a massage, as I told, not only lymphatic drainage, but general massage, and also tattoo and permanent makeup. So it's all in one.
Everything's
place.
there.
Yeah, 24 hours observation. So that's fine.
Fantastic.
And it's my homepage is the same name, excellentbeauty.com.
And I think I don't know if it's true, but the clinic that you work in now, it used to be the house that you lived in.
Yes,
when you were a boy.
Exactly the same age as I am. My parents, my father built up this house.
Yeah.
And he finished the house in 1958. This is my birth, year of birth. And I lived all my life in this house. And my father had his private practice there. And then after his death, it took about 10 years till I finished my training. And then I took it over and started with one room. And then slowly, I built it up, and now it's very all the house.
And I've got to say, it's in a beautiful location.
Yeah.
I mean, Austria is a beautiful country, but you've got some fantastic scenery in the back.
It's nice. It's a little not in the center. It's a little, but Innsbruck is very small.
Yeah.
It takes about half an hour to pass through
But there's some great sausages in the supermarket as well, as I know.
And it's very nicely located, and there's a lot of tourism around. So if you want to stay a little longer and stay in a hotel, we arrange this for people from outside and take care in the meantime. So
okay. Well, Karlo Hasenohrl, vielen Dank für alles.
Gerne
Es
geschehen.
war fantastisch.
I have one thing.
Okay.
You're always wearing sweaters or T-shirts with German.
Yes.
So I brought something for you.
Oh, amazing.
With
Amazing.
Carlo.
Thank you so much.
So this is for you to keep me in mind for our place.
That is very kind. Thank you so much. That's brilliant.
Perhaps I see you once in one of your
Yes,
podcasts.
I will. I'll wear it in the next podcast. Thank you.